Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan salam sejahtera. Hadirin sekalian, bagi memulakan majlis kita pada pagi ini, majlis dengan hormatnya mempersilakan hadirin untuk berdiri bagi sama-sama menghormati dan menyanyikan lagu negaraku serta lagu Universiti Malaya. Silakan.
Universiti Malaya, kebanggaan kita semua, bertambah para ilmuwan di berbagai lapangan. Kami bertekad di hati mencapai cita murni, tradisi kerja dan bangsa. Varsity kesayanganku, sungguh banyak jasamu membentuk insan mulia, berilmu berbudaya. Di sini kami sedang berbakti, terus berinovasi. Kami harapkan generasi muda teras nusa dan bangsa. Varsity kesayanganku, sungguh banyak jasamu membentuk insan mulia, berilmu berbudaya.
Terima kasih hadirin, dipersilakan duduk. Baiklah hadirin sekalian, majlis pada pagi ini ingin mengalu-alukan kehadiran yang dihormati Dr. Muhammad Saleh bin Yahya, Timbalan Pengarah Klinikal Perubatan Pusat Perubatan Universiti Malaya, yang dihormati Timbalan-Timbalan Pengarah PPUM, yang berusaha Dr. Luqman Ibrahim, Ketua Unit Penjagaan Diabetes PPUM, Ketua-Ketua Jabatan dan Unit, seterusnya tuan-tuan, puan-puan, warga PPUM yang dihormati sekalian. Alhamdulillah, setinggi kesyukuran kehadiran Allah Subhanahu Wa Taala dengan izin dan limpah kurnianya dapat kita bersama-sama dalam majlis perasmian Sambutan Hari Diabetes Sedunia Peringkat PPUM tahun 2021. Di kesempatan ini, majlis sekali lagi ingin mengalu-alukan kehadiran yang dihormati Dr. Muhammad Saleh dan barisan pengurusan tertinggi PPUM serta hadirin dan hadirat sekalian yang mengikuti kita secara atas talian. Baiklah, bagi memberkati majlis ini, dengan sukacitanya mempersilakan Ustaz Muhammad Syazli bin Abdullah untuk memimpin bacaan doa. Silakan.
Bismillahirrahmanirrahim. Alhamdulillahirrabbilalamin. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin. Wa ala alihi wa sahbihi ajma'in. Segala puji hanya bagimu ya Allah, Tuhan semesta alam. Sesungguhnya segala pujian hanya milikmu ya Allah. Kami memujimu, memohon pertolongan darimu dan meminta keampunanmu. Selawat dan salam ke atas junjungan besar Nabi SAW, ahli keluarga baginda serta para sahabatnya sekalian. Allahumma ya Fattah ya Alim ya Allah. Sesungguhnya kami memohon kepadamu agar engkau bukakan kepada kami kebaikan-kebaikan dan memberi kami kemuliaan dalam setiap kebaikan. Sesungguhnya kami panjatkan kesyukuran kepadamu ya Allah, mengizinkan kami berada di majlis yang berbahagia pada pagi ini, sempena majlis perasmian Hari Diabetes Sedunia Peringkat PPUM 2021. Semoga program dan usaha murni ini diberkati olehmu ya Rabbal Alamin. Allahumma ya Rahman ya Rahim. Ya Allah, kami pohon dan mengharapkan inayahmu dengan engkau memberikan kami kekuatan untuk berganding bahu bagi menjayakan hari ini agar objektif yang dirancang tercapai. Ya wasi'al khairah ya Allah, bukakanlah hati kami menerusi aktiviti yang dianjurkan bagi meningkatkan kesedaran masyarakat berkaitan penyakit ini serta impak penyakit tersebut kepada masyarakat manusia khususnya dan penduduk dunia. Allahumma ya Allah, kurniakanlah kebaikan kepada kami yang terlibat secara langsung atau tidak dalam menjayakan program ini. Jadikan program ini program yang berterusan ke arah menjadi wadah terbaik untuk menyebarkan maklumat demi melahirkan masyarakat yang sihat dan sejahtera, seterusnya mampu menjadi modal insan yang menyumbang kepada pembangunan negara tercinta. Allahumma ja'al jam'ana haza jam'an marhuma wa tafarraqna min ba'dihi tafarraqan ma'suma wa la taj'al fina wa la ma'ana syaqiyyan wa la mahruma wa la matruda ya akramal akramin. Wa sallallahu alaihi wasallam Muhammad wa ala alihi wa sahbihi ajma'in. Walhamdulillahi rabbil alamin.
Amin, amin ya Rabbal Alamin. Terima kasih Ustaz. Hadirin sekalian, bagi meneruskan majlis pada pagi ini, dengan sukacitanya mempersilakan Yang Berusaha Dr. Luqman bin Ibrahim, Ketua Unit Penjagaan Diabetes PPUM untuk menyampaikan ucapan aluan. Majlis dengan hormatnya mempersilakan.
Terima kasih Tuan Pengerusi Majlis. Assalamualaikum warahmatullahi wabarakatuh kepada semua hadirin, Timbalan Pengarah PPUM dan semua yang join kita hari ini. Pada hari ini kita menyambut Hari World Diabetes Day atau Hari Diabetes Sedunia Peringkat Pusat Perubatan Universiti Malaya. Pada tahun ini kita meraihkan tahun yang istimewa ataupun special lah untuk pesakit untuk diabetes care ni, disebabkan oleh tahun 2021 ataupun 2021 ni ialah anniversary ke-100 atau ulang tahun ke-100 rawatan insulin untuk merawat diabetes. So it's a 100-year anniversary of insulin. And then pada waktu yang sama juga tahun 2021 ni ialah tahun yang kita paling teruk di impact or di terkesan dengan pandemik COVID-19 atau COVID-19. So jadi pandemik COVID-19 ni telah menjejaskan perawatan diabetes bukan sahaja di Malaysia, bahkan di serata dunia. Jadi tema World Diabetes Day untuk tahun ini ataupun Hari Diabetes Sedunia untuk tahun ini, temanya ialah access to diabetes care. If not now, when? Saya rasa tema ini ialah tema yang sangat bersesuaian disebabkan oleh dua perkara. Nombor satu ialah when we talk about insulin ataupun bila kita bincang tentang insulin ni, one of the issue tentang main issue with insulin ialah cost. So means that despite after 100 years, walaupun sudah 100 tahun rawatan insulin ni available, kos perawatan insulin ni masih lagi out of reach, masih lagi di luar jangkauan kepada banyak pesakit. And when we talk about cost insulin cost ni, kita bukan saja bercakap tentang kos ubat rawatan itu sendiri, tetapi juga kos equipment yang diperlukan untuk perawatan insulin dengan cara berkesan dan selamat. Contohnya glucose strips, glucose sensors, insulin pumps, and access ready access to diabetes care provider. Contohnya in the event of hypoglycemia ataupun hyperglycemia for example, ataupun sick day. So ini saya rasa bagi saya inilah kos yang I think we need to work together to work on providing this access to diabetes care for patient. Nombor dua ialah kenapa tema ini sangat bersesuaian untuk tahun 2021, again because of the COVID-19 pandemic. Disebabkan oleh pandemik COVID-19 ini, ramai pesakit yang tidak dapat datang ke hospital, ramai pesakit yang duduk di rumah disebabkan oleh lockdown ataupun MCO, ramai pesakit yang keputusan bekalan ubat, so they ran out of medication, they ran out of insulin, ramai pesakit yang dapat DKA ataupun hospitalization disebabkan oleh rawatan yang tidak mencukupi di rumah. Jadi disebabkan itu kita juga membuat beberapa inisiatif di PPUM, contohnya dengan pewujudan teleperubatan, penghantaran bekalan perubatan ke rumah, poster service, so untuk memastikan pesakit kita sentiasa mendapat akses towards diabetes care. Dan juga saya juga ingin brief a bit tentang kita punya perancangan untuk open diabetes care unit ni atau unit penjagaan diabetes untuk provide continuous access kepada pesakit diabetes di PPUM. Maknanya bukan sahaja setakat di waktu pandemik ni dan juga di waktu yang bukan pandemik. Jadi pesakit boleh datang untuk troubleshoot ataupun membincangkan tentang apa-apa masalah seperti hypoglycemia, sick day, travel issues, bekalan ubat yang tidak mencukupi atau apa-apa masalah di unit penjagaan diabetes. Sebagai penutup, saya ingin mengucapkan terima kasih kepada Pusat Perubatan Universiti Malaya, especially kepada pengurusan Universiti Malaya, Jabatan IT untuk support mereka untuk menjayakan program kita pada hari ini. Saya juga ingin menyampaikan special thanks ataupun terima kasih kepada kita punya sponsor hari ini, which is daripada Novo Nordisk, 𝒑𝒂𝒌𝒂𝒓 dan juga atas-talian. Dan juga saya juga mengucapkan setinggi-tinggi terima kasih kepada organizing committee yang berusaha keras untuk menjayakan program kita hari ini, dan juga kepada para hadirin yang join secara fizikal ataupun secara online pada hari ini. Sekian, terima kasih. Saya pulangkan kepada pengerusi majlis.
Terima kasih Yang Berusaha Dr. Lokman dengan ucapan sebentar tadi. Hadirin sekalian, majlis kini akan diteruskan lagi dengan ucapan perasmian yang akan disempurnakan oleh Yang Dihormati Dr. Muhammad Saleh bin Yahya, Timbalan Pengarah Klinikal Perubatan, Pusat Perubatan Universiti Malaya. Majlis dengan segala hormatnya mempersilakan.
Bismillahirrahmanirrahim. Yang saya hormati Cik Maria Syabadalia binti Hashim, Timbalan Pengarah Pengurusan. Yang dihormati juga Profesor Dr. Muhammad Zulkifli Abu Bakar, Timbalan Pengarah Klinikal. Yang dihormati Puan Chu Yeyen, Timbalan Pengarah Ikhtisas, dan juga yang saya hormati Dr. Lokman bin Ibrahim, Ketua Unit Penjagaan Diabetes Pusat Perubatan Universiti Malaya. Ketua-ketua jabatan, unit dan seterusnya, tuan-tuan dan puan-puan sekalian, Assalamualaikum warahmatullahi taala wabarakatuh. Terlebih dahulu, marilah kita memanjatkan kesyukuran kita kepada Allah Subhanahu Wa Taala kerana dengan izinnya dapatlah kita bersama-sama hadir secara maya untuk menjayakan sambutan Hari Diabetes Sedunia Peringkat PPUM bagi tahun 2021. Di sini saya ingin mengucapkan tahniah kepada semua warga kerja daripada unit penjagaan diabetes di atas kejayaan melaksanakan program ini. Sesungguhnya untuk menjayakan sesuatu program bukan perkara yang mudah dan memerlukan komitmen yang tinggi dan penuh dedikasi dari semua ahli jawatan kuasa yang terlibat. Hadirin dan hadiran yang saya hormati sekalian, tema yang dipilih oleh International Diabetes Federation pada tahun ini adalah 100 tahun insulin akses kepada rawatan diabetes. Tahun ini genaplah satu dekad sejak penemuan bersejarah insulin yang telah menyelamatkan banyak nyawa. Penemuan insulin juga menjadi titik tolak kepada penciptaan ubat-ubatan terkini dalam rawatan diabetes. Walau bagaimanapun, masih terdapat jurang dalam akses perkhidmatan diabetes, lebih-lebih lagi ketika negara berhadapan dengan pandemik COVID-19. Sehubungan dengan itu, program secara maya seperti ini berpeluang untuk menyebarkan ilmu pengetahuan yang tepat dan membantu meningkatkan kesedaran diabetes dengan lebih meluas kepada masyarakat umum. Hadirin yang saya hormati sekalian, pada tahun 2020, seorang daripada 5 individu dewasa di Malaysia didapati mengidap penyakit diabetes. Kelaziman ini amat merisaukan kerana diabetes bukan sahaja berkaitan dengan tahap gula yang dalam badan semata-mata, tetapi juga berkait rapat dengan organ-organ lain. Penyakit kronik ini juga jika tidak dikawal boleh menyebabkan kerosakan komplikasi jantung, buah pinggang, mata dan juga kerosakan saraf. Pengurusan diabetes ini melibatkan pelbagai aspek dan multidisiplin termasuk pakar endokrin, jururawat khusus diabetes, pakar nutrisi, pakar mata dan sebagainya. Disebabkan itu, unit penjagaan diabetes ditubuhkan sebagai satu inisiatif untuk memudahkan perawatan diabetes di PPUM mendapat semua rawatan secara sistematik dan holistik di bawah satu bumbung. Saya berharap dengan diadakan program seperti ini akan dapat membantu menyampaikan informasi berguna dan meningkatkan kesedaran di kalangan warga PPUM dan orang awam khususnya. Pesakit serta ahli keluarga mereka mengenai kepentingan penjagaan diabetes untuk membantu pesakit berdikari dan lebih positif dalam menjalani kehidupan seharian. Akhir kata, dengan lafaz Bismillahirrahmanirrahim, saya dengan ini merasmikan Hari Diabetes Sedunia Peringkat Pusat Perubatan Istimewa tahun 2021. Sekian, wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi taala wabarakatuh. Ni apa ni?
Baiklah hadirin sekalian, bagi meneruskan majlis, dengan hormatnya mempersilakan Yang Berusaha Dr. Lokman Ibrahim untuk menyampaikan cenderahati kepada Yang Hormati Dr. Muhammad Saleh. Silakan. Baiklah hadirin sekalian, kini majlis akan diteruskan lagi dengan sesi bergambar kenang-kenangan. Dengan itu, majlis memohon jasa baik para hadirin yang mengikuti kita secara atas talian untuk membuka kamera untuk kita dapatkan screenshot. Okey, kita sedang menantikan hadirin yang berada di atas talian untuk membuka kamera untuk kita dapatkan tangkap layar ataupun screenshot. Okey, dengan kiraan 3 kita dapatkan screenshot. 1, 2, 3. Okey, kita akan buat lagi 2 screenshot. Mohon hadirin untuk terus berada di atas talian. Okey, dengan kiraan 3 kita dapatkan screenshot freestyle pula. Okey, 1, 2, 3. Baiklah hadirin sekalian, dengan demikian maka sempurnalah sudah majlis perasmian sambutan Hari Diabetes Sedunia Peringkat PPUM tahun 2021 pada pagi ini. Majlis sekali lagi ingin mengucapkan jutaan terima kasih kepada Yang Dihormati Dr. Muhammad Saleh di atas kehadiran merasmikan majlis kita pada pagi ini. Terima kasih juga diucapkan kepada hadirin yang mengikuti kita secara atas talian. Akhir kata, sehingga bertemu lagi, sekian wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih.
Morning to everyone. Welcome to the World Diabetes Day UMMC 2021. My name is Dr. 𝗛𝗶𝗗𝗂𝗏. I am the Medical Officer at the Department of Medicine UMMC, and I will be your moderator for the first and second session for today. First of all, thank you everyone for joining us in our event today. We have a list of incredible and informative topics lining up for you today, so do stay tuned until the end. As we all know, 2021 is special because it marks 100 years since the discovery of insulin. Hence, this brings us to the very first topic for today, Diabetes Care, the 100-year journey. This very timely topic will be presented by Associate Professor Dr. Lim Lee Leng, who is the Consultant Endocrinologist at the Department of Medicine, University Malaya. Prof. Lim is involved in numerous research and publications in high-impact journals. She is also a part of working groups of the Lancet Commission on Diabetes and the Precision Medicine in Diabetes Initiative. Her major areas of interest include cardiometabolic medicine and intergenerational diabetes with translational and implementation science components. But before we start, allow me to explain a few house rules. For all the curious minds out there, if you have any question, please type and submit your question on the comment section during the talk, and we will try our best to address this question in the Q&A session after the talk. So without further ado, I invite Prof. Lim to present our first topic.
Thank you, Dr. Ida, for the kind introduction. Good day, everyone. I'm Dr. Lim, who is a consultant endocrinologist at UMMC. It is my pleasure to share the 100-year journey of diabetes care during the UMMC World Diabetes Day celebration. I will present 5 major discoveries in the past 100 years and highlight what we may expect in the future. The year 2021 marks the centennial of Banting and Best's landmark description of insulin discovery. This discovery and insulin's rapid clinical deployment have transformed diabetes, especially type 1 diabetes, from a death sentence into a medically manageable long-term health condition. At that time, the University of Toronto physiology professor MacLeod agreed the idea from Banting was worth testing on the condition that Banting could devote all of his energies to the project. Banting and his biochemistry student Charles Best began their experiments under MacLeod's direction at Toronto. After repeated failures and refinement, their pancreatic extract was at last bringing down blood sugar levels. Later, biochemistry professor James Collip was brought on board to purify the pancreatic extract, thereby making it safe for human trials. This figure shows the lab at the University of Toronto where insulin was discovered by Banting and Best. 5-year-old Teddy Ryder was among the first patients to receive the pancreatic extract, co-discovered by Banting and Best. Before that, Teddy's weight has dropped by 10 kilograms. He had lost interest in playing, and he was not able to take more than a few steps on his own. Traveling to Toronto by train with his mother, Teddy received his first dose of insulin in 1922. 3 months later, Teddy was strong enough to return home to his family and a new life in New Jersey. The following year, Teddy wrote a letter to Banting. I wish you could come to see me. I'm a fat boy now, and I feel fine. I can climb a tree. Since then, this 100-year-old discovery has brought about tremendous advancement in insulin therapy, ranging from human insulin to insulin analogs, premixes, and insulin co-formulation, benefiting millions of people with diabetes. And the second major advancement in the past 100 years would be incretin therapy. In the early 1900s, the idea that intestine could produce factors following food intake that can stimulate the release of hormones from the pancreas that can regulate blood sugar level have gained attention. And close to 90 years later, various studies have implicated GLP-1 or glucagon-like peptide 1 hormone as a key regulator of insulin secretion. GLP-1 is known to have multiple benefits, including stimulation of pancreatic insulin secretion following food intake, suppression of pancreatic glucagon secretion, and slowing of the gastric emptying, leading to the satiety sensation with reduced food intake. And to date, incretin therapy, such as DPP-4 inhibitors and GLP-1 receptor agonists, are widely used medications in the management of type 2 diabetes. In 1989, the World Health Organization and the International Diabetes Federation jointly launched the St. Vincent Declaration, calling for active partnerships and commitments from organizations, healthcare providers, patients, families, and communities to tackle the diabetes epidemic. One of the proposed actions was to set up and maintain an integrated care system with help from allied health personnel, such as nurses, pharmacists, dietitians, to perform routine evaluations of patients with diabetes. And this could help in risk stratification, to offer personalized care, and ultimately to influence policy and practice. CPR is a common acronym to be used in this setting. Instead of being famously known as cardiopulmonary resuscitation, in such a case, it means to collect and calculate for personalization and risk stratification. Obesity and overweight are the major risk factors for the development of type 2 diabetes. And we know that the best strategy to reduce the global burden of diabetes and obesity is prevention, in part through early detection and treatment of people at high risk of developing type 2 diabetes, including those with either overweight or obesity. Many trials that are conducted in the high-risk population, with the earliest results announced in 1997, whether they are done in the United States, in Europe, such as Finland, or in the mainland China, have shown that diet and exercise could delay the onset of type 2 diabetes with fewer cardiovascular events, microvascular complications, and death. In terms of physical activity, we recommend at least 5 days a week with at least 30 minutes per session and without more than 2 days of break. And based on the recommendations from the Ministry of Health Malaysia, the typical dietary recommendations to a person with diabetes would be following suku-suku separuh. Half of the serving plate comprises fruit and vegetables, while the other half would be shared by either protein and carbohydrate. Carbohydrate will have included rice, noodles, bread, mihun, and kway teow. A relatively small number of medications have been responsible for major advances in clinical practice. And since 2015, the sodium glucose cotransporter 2, or SGLT2 inhibitors, have been proven effective in the treatment of type 2 diabetes, heart failure, and kidney disease. SGLT2 represent one of the major advances in cardiometabolic medicine in the 21st century. Finally, I will reflect on the future of diabetes management and ongoing transformative work that may be realized in the next 100 years. First will be the closed-loop artificial pancreas system. It comprises a continuous glucose monitor, an insulin pump, and a control algorithm that continuously and automatically regulates insulin delivery in response to real-time sugar levels. This figure shows the evolution of the closed-loop artificial pancreas system from being a low glucose suspend, where once the sensor has sensed that the sugar level have crossed the lower limit, there will be a discontinuation in insulin delivery, to being a hybrid closed loop where a patient with diabetes would have had a continuous glucose monitor, insulin pump with control algorithm, but still needing user-initiated bolusing. And the fully automated multi-hormone closed-loop artificial pancreas system is much anticipated. Okay. Using this device, a patient with diabetes would have had a continuous glucose monitor, an insulin pump, control algorithm, automated. There's no need for user-initiated mealtime bolusing, and this artificial pancreas has both insulin and glucagon hormones to try to maintain glucose level at as near normal as possible. Stem cell technology has been investigated to protect and restore pancreatic islet cells. Stem cells can be generated from patient-owned cells to produce patient-specific pancreatic islet cells, which include beta cell, which produce insulin, alpha cells for glucagon, and delta cells for a hormone called somatostatin. The islets may be transplanted into patients with diabetes to restore their ability to regulate blood sugar levels. Compared with the present pancreatic and islet cell transplantation procedures nowadays, these patient-specific cells are from the patient's own cells, and therefore there isn't any need to give patients any immunosuppressive therapies after transplantation, and therefore minimizing side effects. We also need to bear in mind that type 2 diabetes is a complex and multifactorial condition. The major risk factors include poor diet, obesity, as what we've discussed previously, low physical activity levels, and advancing age. However, twin studies published in the early 1980s suggested that genetic factor can contribute to the risk for type 2 diabetes. And to date, multiple genetic studies have identified more than 550 signals associated with the risk of type 2 diabetes. And in the future, precision medicine approaches, by combining genetic, biomarkers, artificial intelligence, and machine learning, can improve our understanding about disease mechanisms, can help to predict who are at increased risk for diabetes, who are increased risk for rapid disease progression, who are more likely to develop complications, as well as who will respond best to different treatments. This will help clinicians and other healthcare providers to tailor personalized approach in the management of diabetes. As such, thank you for your kind attention, and happy World Diabetes Day.
Thank you, Prof. Lim, for that excellent presentation. Okay, so we have actually collected several questions beforehand for our Q&A session. So let's dive into our Q&A session.
Thank you, Ida.
Okay. All right, so the first question, Prof. Lim, as you have mentioned in your talk, genetic plays a role in diabetes. So can someone avoid getting diabetes if he has strong family history of diabetes? If so, how?
I would say that if we're looking at a person with a diagnosed type 2 diabetes, we know that genetics and environmental factors, especially lifestyle, whether in terms of diet, physical activity, sleeping patterns, air pollution, etc., could actually work hand in hand in the disease process. But so far, even though the genetics have advanced quite a lot compared to 20 years ago, the genetic contribution to the disease process of type 2 diabetes is only about 10%. Another 90% is actually contributed by all these environmental factors that I've mentioned about. So the answer would be yes. If a person with strong family history of diabetes, if you could actually try to adhere to good lifestyle, meaning you have a good sleeping patterns, don't smoke, you're not taking a lot of alcohol, have a good diet and increase of physical activity level, this could actually delay or even prevent the development of diabetes. Over to you, Ida.
Okay, thank you, Prof. Lim. All right, so yes, dietary and lifestyle is very important as what Prof. Lim has said. So if someone already has diabetes, Prof, is it possible for that person to achieve remission with lifestyle and dietary changes? If so, what is your recommendation?
That's a very good question, because in the past 3 years, say since 2018, the UK group actually did try to answer this question. And they found that in type 2 diabetes patients together with obesity, when they were introduced a very intensive dietary restriction up to 800 kilocalories a day, we call it as a direct trial, in type 2 diabetes patients who have been recognized early within the first 6 years of diabetes diagnosis. And they found that close to 60% of these patients were managed to lose at least 10 kilograms of body weight. And this has been translated to the ability to achieve diabetes remission, meaning the patients were able to be off from any of the diabetes medication, whether it's oral or injectable, for at least 2 years. This has rocked the world. And therefore, our concept has changed, where we intend to capture our at-risk patients early, and we try to intervene early to prevent them from the diabetes progression. And especially so, we do not want them to develop any of the heart disease or kidney disease or having their leg being amputated because of suboptimal control of diabetes.
Right. Thank you, Prof. So, Prof, you have mentioned several risk factors for diabetes just now. So, come to our next question. Does the diabetes medication like pills or insulin cause diabetes to be prolonged?
The answer is no. Okay. So medications are to help you. Medications are not to harm you, especially so not only doctors, any allied health personnel, we have the Hippocratic Oath where do no harm to our patients. Medications are to help to improve your sugar level, your blood pressure level, your cholesterol, even the newer generation, like what I've shared just now, the GLP-1 receptor agonist and SGLT2 inhibitors could actually help in weight losing. So together with lifestyle intervention, especially we need to maintain a good body weight. Bear in mind, Dr. Saleh has mentioned every 1 in 2 of our Malaysian population actually have obesity. And we really need to look seriously into this matter, and how are we going to work together with patients, their families and communities to tackle this diabetes plus obesity, diabetes epidemic in Malaysia. We hope that patients or the public, when they listen to us during this event today, they would adhere or comply to the medications, and this would definitely help in the management.
Okay, thank you, Prof. That's a very powerful advice there, compliant to the medications. So another question, what about someone who doesn't have any medical illness? So how does he find out that he has diabetes? What are the signs or symptoms of high blood sugar?
The first thing that we need to get across to the public is diabetes has been long recognized that this is the silent killer. Why silent? Because in general, we see various groups of patients. Number one, they may present to the heart doctor saying that, with heart attack, and only having by that time being checked, being diagnosed to have diabetes. They may present to the kidney doctor with kidney problem, and at the time when they check the sugar level, this actually fall into the diabetic range. So this will be the first group of people being undiagnosed and only present when the complications have already arisen. The second group of people will be those at risk population, and we are hoping that these people will be able to have early detection. How we saying that they are actually at high risk would be you have strong family history of diabetes, your papa, mama, your father, your mother, and even your siblings, we call it a first relative. And then those with diabetes in pregnancy, with obesity, the conditions you are taking steroids. If you just check a medication with prednisolone or dexamethasone, something that we also need to monitor now, as what 𝒑𝒂𝒃 has mentioned, COVID and steroids is one of the management for COVID. So we're also looking hard into this group of people, whether they may be at risk of diabetes. So if they do present with very high sugar level, then there will be increase in thirst sensation. They always feel thirsty. Why? Because they tend to pass a lot of urine, not only daytime, but especially so during nighttime. You can't sleep well throughout the night. You need to wake up twice, at least twice a night in order to pass urine. So all this will be some of the symptoms. Another one is marked weight loss. They may think that, oh, I actually managed to lose weight. But actually it's not. If you fall into the at-risk population group, something that you read, and this could be the red flag, and it is advisable for you to go through the health screening.
Okay, thank you, Prof. So we actually have a lot of questions about what are the risk factors for diabetes. And I think, Prof, you have mentioned a lot of risk factors there. Okay, the next question. If the diabetes patient who is on oral medications or pills did not control his food intake, what will happen? Does that mean that he has to switch to insulin straight away?
No, we need to tackle the problem. So the problem is why patient, he or she can't comply to the oral medications, can't comply to the dietary restriction. So diabetes is not a one-man show. Diabetes is a teamwork. So as what Dr. Saleh and Dr. 𝒑𝒂𝒃 has mentioned during the opening speech, integrated care system is of utmost importance, and therefore UMMC has really set up the diabetes care unit. We work together with our nurses, our diabetes nurse educators. We work together with dietitians for tailored dietary advice. We work together with pharmacists, where pharmacy could also help us to tackle any of the adverse event or side effects that could arise from multiple medications. We talk to the patients and family to get to know what will be the underlying problem that can potentially contribute to the suboptimal diabetes control. So this is a personalized care. This is not a one-size-fits-all approach. We don't just say, oh, your diabetes control is not good, your sugar is high, then we scold you for a few minutes, and later on we say, okay, just take insulin and go home. No, that's not the correct way.
Okay. Thank you, Prof. Lim. Yeah, so the intervention is not just pills and medications and insulin, but also it's a multidisciplinary approach and personalized as well. So, Prof, we have a last question here. Are there diabetes cases among children aged 12 years old and below in Malaysia?
Yes, that's again another good question. One thing that we have every 1 in 5 in the Malaysian population adult has diabetes. But if you look through our pediatric registry, 18% of the diabetes population among the pediatric age group are actually having type 2 diabetes. And in general, the mean age would be 10 to 15 years old. It's an alarming phenomenon because not only in Malaysia, but also at a global level, we're seeing that the onset, meaning at what age that a person may develop diabetes, has shifted from the older age group. Usually we say it's more than 40 years old, but now we're seeing younger and younger population. Not only in the young adults, around 20 to 30, we're also seeing a higher increasing number of cases of pediatric age group having type 2 diabetes, meaning related to the lifestyle. Western, KFC, McDonald's, Burger King, pizza, all this would have contributed to that.
Okay, thank you, Prof. Yeah, so diabetes is not only affect the adult population, but also children. So it's important to test and screen if you have the high risk factors that Prof has mentioned earlier. So those are the only questions that we have for today, Prof. So thank you for addressing all these burning questions. I wish we could have more time to answer this question, but in the interest of time, we have to move on to the next session. Thank you very much.
Thank you, Ida.
Now, moving along to our next session, please welcome our very own Dr. Luqman, the head of Diabetes Care Unit, or DCU. He's going to talk about the introduction of DCU in UMMC. So we will start first with a video, and then Dr. Luqman will give us a short brief about Diabetes Care Unit. Again, if you have any question, please submit on the comment section below, and Dr. Luqman will address the questions after the video. Thank you for that video that's actually specially created by our sister and staff nurses of DCU. Okay, so Dr. Luqman, would you tell us about what DCU is?
Yeah. We started Diabetes Care Unit sometime around 2012, 2013. At that time, this was an idea to provide diabetes care as a one-stop center. Basically what it does is that it combines food care, eye examination, and diabetes education. But over time, we have evolved into something that provides more than just one-stop center. We have evolved into some form of integrated care that provides a more personalized care to patient, and we treat them on a continuous basis, and of course we try to provide access to any problem that might come up, might arise in patients' daily lives.
Okay, very interesting. So, Dr. Luqman, what are the criteria of diabetes patients that should be under the care of DCU?
In general, as long as we have a few services in diabetes care unit, we have this comprehensive assessment. We do comprehensive assessment, we do eye examination, food examination, as well as diabetes education. This service is actually accessible to everyone, even to the public as well. Meaning that you do not need to be a patient in a diabetes in a University Malaya Medical Center to attend or to receive this comprehensive assessment in diabetes care unit. But at the same time, we also provide more personalized care for our patient, especially for type 1, patient with difficult type 2. What we do is that if let's say you have a patient with type 1 diabetes, we provide training for you, especially in terms of glucose monitoring, sick day, sensor use, and sometimes pump use. If you have type 2 diabetes, we provide other issues, follow up like insulin initiation, insulin titration, and other skills lah. Yeah.
Okay. So, Dr. Luqman, you know, during this pandemic, people are scared to go to hospital. So, does DCU offer online service or virtual consult?
Okay. We do observe the same. We have the same observation as well. We find that during lockdown, a lot of patients, they have limited mobility. They cannot come to hospital. They ran out of medication. I think this is not just DCU, but even the entire hospital also, we come up with plans to cater for this, to address these issues. Number one is that our pharmacy, during the time of the lockdown, have been delivering medications to home. Yeah, so meaning that if let's say the patient appointment has been postponed or they cannot come to the hospital because of lockdown or because of other reasons, they just need to call the pharmacy and then pharmacy will send their medication to their house. Yeah.
Okay.
So this was provided early on during the lockdown period because this was something that we thought about early on. And then later on, we worked to develop teleconsultation. So we do have our patient with diabetes who, instead of coming to the hospital, they attended consultation via online meeting. This also we provide training for them on how to go through this teleconsultation process. But at the same time, despite this, we still have patients who don't have who still have problem with their care, namely usually for acute issues. For example, like hypoglycemia, hyperglycemia, sometimes sick when they are sick, for example, when they get fever, when they ran out of medication, when they are notice that glucose is high or they are not feeling well, for example. So for this kind of patient, we do provide access to them as well. Because they can't come to their clinic, right? They can't come for their appointment. So if there's other issue, then they can come to us and we try to address this problem. We've had a few patients who come with issues related to, for example, like medication adjustment, patient who ran out of medication, continued prescription, and other issues that our nurse and doctors can address during the time of the pandemic.
Okay. Thank you, Dr. Luqman. So we try to make it convenient for our patient with all the teleconsult, but at the same time, we have to take note of all the signs and symptoms if we get worse or anything at home. Okay, Dr. Luqman, there's another question. So DCU also offers eyes and feet check for the diabetes patient. But the question here is, how often does diabetes patient has to check their eyes or their feet?
Okay. In general, it's not just the eyes and feet, because I think this is something that we try to address in a lot of our patients. When we treat patient with diabetes, it's not just about prescribing glucose lowering medication. Diabetes treatment is, at the end of the day, aims to prevent complication and improve quality of life. And when we say about we want to prevent complication, this of course involves controlling blood glucose or lowering blood glucose, as well as controlling blood pressure, cholesterol, and screening for early screening for complications. Yeah, so the kind of screening that we do includes screening for the metabolic syndrome, like for blood pressure, for cholesterol levels, screening for albuminuria as well, screening for early kidney problem, and then yes, we do arrange screening for eye and food complication as well. Okay, in general, as a generalization, this screening needs to be done at least once a year for all patients with diabetes who do not have complication. But once they do get complication, then these screenings need to be done more frequently. So for example, if let's say a patient who was detected to have albumin in the urine, for example, right? So this patient will need to have a albumin urine test repeated to confirm the persistence of albuminuria.
Right.
Or if a patient has abnormal eye examination, for example, so this patient would need to be seen more frequently to decide whether this patient needs urgent treatment or not. So the urgency or the frequency of examination also will depend on the severity of complication. For those whose screening tests are normal or who do not have any complication, they can be screened once a year. For those whose screening test is not normal, they might need to be seen more often. Otherwise, the other tests like HbA1c, or we do like every 3 to 6 months.
Okay. Thank you, Dr. Luqman. That's a very comprehensive and informative answers there. So that actually wraps up our second session for today. Do you have anything other you mention, Dr. Luqman?
I also wanted to add on that I think we try to, in diabetes care unit, we try to, our philosophy is that we provide care in a personalized way, or in a multidisciplinary but personalized way. So meaning that we try to promote the concept that we learn together with the patient. So the patient learn to work with us. The patient learn about their disease, learn about their healthcare provider, and at the same time we also learn about our patient.
Right.
So because each patient is very different, they all have different social circumstances, they all have different background. So not all treatment will work for all patients. So how do we know what treatment will work best for a certain particular patient is by us knowing the patient. So I think it's important for us to have a lasting, ongoing relationship between a patient and their diabetes care provider. And this is something of a concept that we try to promote in diabetes care unit, that we learn to know our patient and provide care for them on a long-term basis.
Okay. So it's a personalized approach, and no one size fits all. Okay. Thank you so much, Dr. Luqman.
Thanks, Aida.
All right. So we'll go on to the next session. Thanks. Thanks.
Hello, good morning, everyone. I'm Dr. 𝒑𝒂𝒌𝒂𝒓, a medical officer from the Department of Medicine, University Malaya Medical Center. I'll be the moderator for the third session of the day, which will be on self-monitoring of blood glucose. Allow me to introduce the speaker for this session, Staff Nurse Shamila from the Diabetes Care Unit, University Malaya Medical Center. She will be sharing with us some tips on self-monitoring of blood glucose at home. If you have any questions on this topic, do write it in the chat box on YouTube. First, let us watch this video.
This video will focus on how you can perform self-monitoring of blood glucose, or in short, SMBG, in your daily lives. Firstly, why is it important to perform SMBG? Having a systemic record of your blood glucose readings is important for a number of reasons, including to determine the correct dose of insulin and adjust the doses if necessary. Diagnosis and treatment of hypoglycemia. Monitoring of glucose levels during special situations such as acute illness or fasting when the glucose levels can be unstable. Close monitoring of blood glucose during pregnancy, which is important as uncontrolled diabetes in pregnancy can lead to unwanted outcomes. Next, What do you need to perform SMBG? You will need a functioning glucometer device and the compatible strips, lancets for finger prick, and lastly, a diary to record down the blood glucose readings. The blood glucose diary can be in a form of manual record or a digital diary. How do you perform SMBG properly? Firstly, clean your hands by washing them thoroughly with water and soap. Next, insert the strip into the glucometer device and ensure the device is ready for reading when the indicator flashes on the screen. After that, load an unused lancet. You may use to choose the shortest lancet depth to draw the minimum required amount of blood. Prick the lancet at the side of your fingertip. Squeeze 1 drop of blood onto the glucometer strip. Now, wait for the glucometer to generate glucose readings. While doing that, compress on the finger prick side with a clean tissue paper until the bleeding stops. Finally, document the glucose readings in your glucose diary. When should you check your SMBG? SMBG frequency is individualized based on your treatment needs. Patients with type 1 diabetes or pregnant women with diabetes require multiple readings in a day. Patients with type 2 diabetes on insulin therapy may require 1 or more readings per day in a structured manner, usually before meals, depending on the insulin treatment regime. Patients on oral treatment generally do not require regular SMBG, but may do so if they find it helpful to monitor their glucose levels. What are the target glucose levels? Target glucose levels are individualized based on age, medical conditions, and risk for hypoglycemia. Digital SMBG diaries. Certain glucometer devices can be paired with smartphones to automatically upload glucose readings from the device. Digital SMBG diaries can help in interpreting the trends of your blood glucose levels in a faster, convenient, and comprehensive manner. CGM. Certain continuous glucose monitoring or CGM devices can monitor glucose continuously for a certain period of time and analyze the data to show the ambulatory glucose profile, which shows the average glucose readings at different times of the day. CGM use has been shown to improve HbA1c levels and reduce the risk of hypoglycemia in certain people with diabetes.
That was a very informative and concise video on self-monitoring of blood glucose. There are some questions for you, Shamila. How important is it for us to monitor our blood glucose at home?
First of all, I would like to stress on few points. Why is it important on doing your SMBG, which is self-monitoring of blood glucose? Okay, firstly, when you are a diabetic, don't you want to know your records? Whether your sugar reading is, how bad is your sugar reading or how good is your sugar reading? Is it becoming worse or is it becoming better? So it is for your own records. You have to keep track on your sugar reading, firstly. Okay. Secondly, the doctor needs to know whether they have to start you with any oral medication or any kind of treatment. It can be either oral medication or on insulin. So in order for the doctors to do that, you need to have your sugar monitoring record. We can't simply give you medications based on your sugar monitoring. We need to know whether oral medication is suitable or insulin. Okay. Thirdly is for your hypo treatment. Okay, let's say you're going through hypo. How you want to know whether you're going through hypo? Yes, you can know it through your symptoms, one. But whatever it is, you have to basically do your sugar testing. You have to do your sugar testing in order to know whether you're going through hypo, because there are certain level where you have to know what level is it in order for you to do your hypo treatment. Okay, second will be your dose adjustment. Why is it? Because once you're either on oral medication or also on insulin, normally we won't be like maintaining your dosage forever. We need to adjust according to your readings. Basically, it's for oral medication or even insulin. We will try to help the patients as much as possible to minimize their medications and also to decrease their dosages. So in order to do that, we need your readings. You have to do your daily monitoring. Okay. Lastly, during your sick day management, okay, most of the time you'll be only checking like 2 times or 3 times in a day. But during your sick day, we would want you to test your sugar more frequent. And why? Because during sick day, when you're not feeling well, you're having infection, you're having inflammation, you don't have appetite, your stress level goes high. All these things will add on to your sugar and it will spike up your sugar. So in order to know whether your sugar reading is high, you need to monitor regularly. So these are the certain things. Why is it you have to know and why is it you have to test your sugar? Thank you, Dr. Koo.
Thank you, Sharmila, for that very comprehensive answer. So how frequently should we actually monitor our blood glucose at home?
Okay, frequency of testing your blood glucose, this one depends, this is individualized. Okay, I have 2 categories here actually, whether the patients are on oral medication or even on insulin. It depends on the patients whether they want to do it daily. Some patients, they would prefer to do it daily actually. They would prefer to do it daily and some even weekly once and some even will be doing for 2 days, for 2 consecutive days, which we would prefer. So I would split it into 2 for oral medication and also for insulin users. Okay, for oral medication, for those who are on oral medication, mostly we would prefer them to test 4 times in a day, which includes your fasting, 2 hours after breakfast, 2 hours after lunch, and also 2 hours after dinner. It depends on you if you want to do it weekly once or 2 consecutive days. Normally, from my personal experience, we have patients who will be coming for sugar monitoring review, but then at the end of the day, they'll come empty-handed. So as far as possible, we would try to give them some choices. At least they can monitor their sugar level at home. Okay, that's for oral medication users. Okay, for insulin users, we would prefer 4 times as well, but it will be all pre-meals, which will include your fasting, which is important, pre-lunch, pre-dinner, and also pre-bed. And you will be doing it for 2 consecutive days as well. Thank you.
Thank you, Sharmila, for that answer. What is the target for our blood sugar before and 2 hours after a meal? And how exactly do we define 2 hours after a meal?
Okay, this one depends on the individual as well. Okay, basically for pre-meal target, we would definitely prefer between 4 to 6, anything less than 6. And for post-meal, it is between 4.4 to 8. So, and that also depends on the age of the patients. Okay, for those who are 20s, 30s, and 40s, and even 50s, at the age of 50s, we would prefer them to have their pre-meal sugar below 6. But for those who are 70s and above, 70s, 80s, and 90s, and more than that, we can't expect much to restrict them and get the target range of below 6. So for me, in my opinion, it would be better if at all they can even manage to get below 7 or even below 8 for their pre-meals. And for post-meal, it will be, the target range will be between 8 to 10. As long as their sugar level is below 10, we are more than happy to accept the reading actually. These are the target ranges for certain ages. Okay, 2 hours postprandial. Okay, 2 hours postprandial, how do you test it? Okay, most of my patients, I will ask them back the question of how do you test when you are testing your sugar for 2 hours? The common answer that I receive is after I finish my meal. Okay, actually the calculation starts once the minute you put your first mouthful in, that's when your counting starts for 2 hours of postprandial. from the first mouthful in, start eating, start counting. Okay, there would be questions like, can I munch between that 2 hours? Okay, the answer is no. You are not supposed to munch, and you're not allowed to munch anything between that 2 hours. Why? Because it will interrupt with your sugar reading when you test your sugar after 2 hours. And how long do you take to finish up your meal? It's between 15 to 20 minutes. I understand most of us will sit in front of the TV and will drag our meal time. But then when you're testing the sugar for 2 hours, it's important for you to really calculate the 20 minutes because we want an accurate results in order to start your medication or anything. So that's how we calculate the 2 hours. And also your meal, it's supposed to be your normal meal. You don't add on with extra sugars or anything. Your snacking will come after you have tested your sugar. That's how you calculate for 2 hours after meal.
Thank you very much for that clarification. Who should perform a 7-point blood sugar monitoring at home?
Okay, basically 7 points. We would normally prefer for gestational mothers who are pregnant mothers. It doesn't matter. Sometimes even for type 2 diabetes or type 1 diabetes, they will be doing 7 points. But normally we would prefer for pregnant mothers. Why? Because we want to monitor their sugar regularly, close monitoring before and after meal. The 7 points includes their fasting and 2 hours after breakfast, before and after lunch, before and after dinner, and also pre-bed. This is what we call the 7 points. So mainly is for pregnant mothers. But anytime, by all means, if at all for those who are type 2 who are willing to do 7 points for 2 consecutive days or even daily, they can always do that, and that's even better. Thank you, Doctor.
Thank you very much for answering all those questions, Shamila. As you can see, the monitoring of glucose, much like the management of diabetes, is very individualized. So let's move on to the next session, and I'll hand over to Dr. Lim Kuan Jeong. Stay tuned for more interesting topics coming up.
Shamila for that very informative session previously. My name is Dr. Lim Kuan Zeong, and I will be moderating this talk entitled Diet and Diabetes, Striking the Right Balance. First of all, let me introduce to you our panelists today. Because diet is such an important part of diabetes care, we are lucky to have it with us today, not one, but two very experienced dietitians to talk about diet and diabetes. On my right here is Dr. Lee Ching Lee, a dietitian and lecturer at IMU. She holds a PhD in medical science, where her work involved helping patients with diabetes lose weight and achieve better sugar control by changing the way they eat. Mr. Muhammad Hazrin bin Hussein is a dietitian who works at University of Malaya Medical Center, and he works together with doctors and nurses to deliver diabetes care at the diabetes clinic and diabetes care unit. To the audience watching live with us, you may key in any questions in the chat box and we will address them. Without further ado, let us get started by looking at some questions submitted to us beforehand. Okay, question number one. As a diabetes patient, how do I tailor a healthy diet with the local Malaysian food?
Okay, Assalamualaikum and good morning to everyone. So thank you for inviting me today. So straight to the question. So how do you tailor a healthy diet with the local Malaysian food? As we know, Malaysian food is if you see a lot of high in fat, content of carb is more. So the first thing as a diabetes patient need to know is the macronutrients, which is a carbohydrate source, what is the fat source, what is the fiber, protein. So once you know that, then you can enjoy your diet happily. Because as a diabetes patient, you need to know how much carbohydrate do you need and what type of carbohydrate do you should choose. Is it complex carb, high in whole grain products, limit the refined sugar? That is very important. Then you must to choose what is the best cooking method, how they prepare, is it high in fat or not. So try to choose that lower in fat use, such as steam, soup, bake, instead of you take that one that fried, which high in fat, because high in fat also can affect to your blood sugar level control. Yeah.
Thank you, Mr. Hazrin. So you've mentioned about how we should pick the correct food groups and know how much to take, as well as how the food is prepared as well.
Yes.
What about Dr. Lee? Do you have anything to add?
Yes, I think what Hazrin has mentioned is quite important. So if you have diabetes, really recognize where your nutrients come from food. That will help you make better choices. But I think maybe to add as well, because we talked about cooking, right? We talked about food selection, and we talked about food preparation. But in shopping, let's just say if you go grocery shopping, I think that's one of the important things you can plan ahead. And most Malaysians love shopping, isn't it? So when you go shopping for food, make sure you don't go shopping on a hungry stomach. If not, you buy too much food, right? And try as best to plan your shopping before shopping. So make sure that when you buy foods, you have wholesome foods, you have fresh foods there, all your food groups are there. So then you limit the amount you spend on, say, unnecessary food. That's important. I think that's about what I would like to add.
Yeah, I think that's an excellent tip, Ching Lee, because I think these are the little tips and tricks that we don't realize, and these are the traps that often as Malaysians we fall into, having the wide amount of selections that we have. Okay.
Yeah, that's right.
But yeah.
Can I? Yeah. It just occurred to me now. Festive season is coming as well.
Yes.
So year end, at work, when you celebrate with your buffets, now that we are open up, we can go and dine out already. You're going to come for New Year's. Then next is what? Chinese New Year, Hari Raya, and things like that. So if you have diabetes, you can still enjoy your food, but remember, always plan ahead. So watch your portion sizes. You don't have to eat everything at one go, right? So plan ahead. Do I want my nasi minyak and nasi biryani, or just a little bit of both? Don't tambah. So plan ahead before you celebrate, and that will be good, right? And if it all fails, exercise, right?
Yeah.
Try and burn off the extra calories, right? Try and use up the glucose that comes from food. So how do you exercise? Clean your house, clean your car, things like that. If you visit your friends park further away, then use the stairs, and I think you'll be able to manage and enjoy.
Yes, excellent. I do agree that the key point here is planning ahead. What you want to buy, what you want to eat, how you want to prepare the food. And I think that is the key takeaway point here for this question. I think having a proper planning before we actually and avoid impulsive eating, definitely. Yeah. Okay, what about the next question? So as a diabetic patient, should I follow a strict diet plan? There are so many diet plans out there. You have the Atkins diet, the ketogenic diet, low carb diet, protein diet, paleo. I don't know. So if as a diabetic patient, which is the most suitable diet plan for me?
So maybe I'll start first, Hasrin. Yeah. There are many diet plans out there, and it can be very confusing, right? Let's just say if you know that, let's just say you say, I've been diagnosed with diabetes, I need to lose weight. So you Google search, right? Okay, or any other search engines. Then all these diet plans come out. So what you need to know is all the different diet plans, they're different in that they prescribe different macronutrients. Just now Hasrin talked about where your carbohydrates come from, your proteins come from, your fat comes from. So all these different diets will contain different proportions of the macronutrients. Now, which diet is best for your health outcome? That one you really need to sit with your dietitian, your doctor, because different people will have different health outcomes. You may have diabetes only, you may have diabetes with hypertension, you may have diabetes with chronic kidney disease. So all these three will have different diet needs. Okay, so that's that. You can choose the right diet when you talk to your healthcare professionals as a team. Number two, if you look at research data, which diet works the best? Actually, any diet, if you follow, it's healthy. You can follow the diet, that's the best diet for you. So you must look for a diet that fits into your lifestyle, right? Because it's not like I follow a diet plan today, then I eat well, then everything is fine. It's not a cold when you're managing diabetes. It's every day, you're living with it, you manage it, right? For a long time. Maybe you live until you're 90 years old. So the diet has to fit in your lifestyle.
Yeah, correct. Okay, all right. For me, I see the patient, most of the patient, they try to do, maybe they already start with a diet such as like 𝒑𝒂𝒌𝒂𝒓, intermittent fasting and everything. But the question is the sustainability of the diet and then the risk of the rebound of the weight. So let's say if you want to practice intermittent fasting, then they want to lose weight. So some of the patients just can maintain about 1 month or 2 months. Then after that, after they back to the normal diet, the weight and the blood sugar level maybe go up again. So that's why dietitian always suggest to patient to do a healthy and balanced diet back. That is the best way and the best sustainability for the patient to follow. That is number one lah. And then number two, just now, patient need to have a balanced meal means all the macronutrients must be in your meals, because let's say they practice high fat diet, low in carbs. So some of the vitamins and minerals, fibers intake might be not sufficient for them. So that can be worse to their health. So that's why what is the best, I think, is go for the healthy diet. Your calories, maybe 1,200 to 1,500. Then you maintain your body weight to normal range. So I think that is the best way to control your diet.
May I also add something? As a doctor who manages diabetes patients, I would also like to emphasize that if you are a diabetes patient that, for example, you have type 1 diabetes and you wish to subscribe to a certain form of diet, for example, especially the ketogenic diet, please speak to your doctor first and see whether are you really suitable to subscribe to such and such diets. On top of, whether, and at the end of the day, you also need to focus on what your goals are, what you are actually trying to achieve. Are you trying to lose weight? Are you trying to improve your sugar control? Are you trying to control your lipid levels? Okay, so there are a lot of factors in play here, but definitely what you have both mentioned is very important. A diet plan that you can stick to and that is feasible for you to maintain in the long run. And really, it really isn't about subscribing to a plan like, Maxis DG, and then 2 years later, I don't like it anymore, to switch it out. it doesn't work like that,
Yes,
right?
it
Yeah.
doesn't.
Thank you for the excellent answers. Let's move on to the next question. So yeah, I think this is also a question I always ask myself. What is more important? What I eat, how much I eat, or what time I eat? Is it bad if I eat supper? Is it bad if I eat at 2 a.m. in the morning? No, what do you all think about this?
Okay. On the question, I think all of this is important lah. So, but I think the most patient that I see that facing the problem is meal times. Okay. So I always ask patient to emphasize the proper meal time and correct meal time, because some of patient they just okay, because I have a diabetes, then I cut down meal time to 1 or 2 times a day. So that is not a good idea, because if you have just 1 or 2 meal time, that means your fasting period is longer. So that's why some of patient cannot sustain with it, and then they can take something else in between, which is can affect to the blood sugar level. So the most important for the diabetes patient is they must have a proper meal time. Okay, and then once they know what is the proper meal time, the next is they must to know what is the requirement of energy from the food lah. So either how many calories, that is you need to discuss with a dietitian. What is your target? Is it you want to losing weight or what? So the calorie you can discuss with dietitian, and then after that, once you know how many you take, then how you arrange your all the macronutrients, which is you need to meet all macronutrients balance. So that's what that is your carbs, your protein, your fat. So you must to make sure that is balanced.
Yeah. You have anything to add?
Yes. So that is really an excellent answer by Hazrin. And I think just wanting to add on to when you eat. So depending on the type of diabetes you have, your medications might change. And so some of you might be on insulin or on certain oral medications that need to match the timing of your meal. So make sure you talk to your doctor, talk to your dietitian, talk to your diabetes educator, and identify, make sure your meal timing matches your medication timing. So then you get beautiful blood sugars. Yeah. Then I think just to add on to what I eat, is it or what's the other one? How much I eat. I'm trying to read the top there, right? We must first remember when you're eating with diabetes, is of course for health. So it's your weight, your blood sugars, your blood cholesterol, your blood pressure. All right. But what people always forget is that food also contain nutrients, your vitamins, your minerals, your phytonutrients. So when you choose what you want to eat, you want to choose food that has also got a lot of nutrients. So for example, let's just say if I have a tin of carbonated beverage, okay, that will be maybe about two slices of bread in there, carbohydrates. I might as well just eat, say, 2 slices of bread, because the bread will then have other nutrients compared to just the sugar. So you've got to pick food that also contains nutrients, because you're feeding your body.
Yes. Yeah, I agree with you, Ching Lee. But I also personally feel that a huge issue that Malaysians face is not realizing how much to eat. They feel, a person's definition of nasi sikit, nasi may be very, very different from another person. Okay, and I feel this is a very important thing to sort of educate the public on what is the proper portioning of food that we should eat. And also it also should be tailored according to our physical activity levels, isn't it? For example, a person who's doing manual work may need different levels of energy as compared to a person who's doing sedentary office work 9 to 5. Okay, so we should definitely tailor our portions of our food, right?
Yeah. So I think we have very useful stuff here. So this is what we call the dietitian's tools. It's also your tools, as patients. These are all house items, right? You can use that to help you identify how much you should eat.
Yes.
Yeah, this belongs to Hazrin, right? Can I show? You want to? So this is the healthy plate model.
Yes.
And in general, I think if you eat according to this style, right?
Yes.
You are there.
Yeah.
With just a little bit of tweaking for different patients. Yeah.
Because the healthy plate model
Okay, you
is
talk, then I show.
Balik.
okay. So healthy plate concept is actually we emphasize on the balanced meal. So you have all the macronutrients, which is you have a carbohydrate, quarter of your plate, and then you have your protein, and then you have your vegetable and fruits. So if you take outside, okay, if let's say you don't have all the bowls in front here, you can estimate using this plate. Okay, so if you practice this one, so then you know your meals is actually balanced or not. If let's say you don't have rice, so your cups maybe can be your bread, okay, and then you make sure you have your protein. Protein means if you take bread, maybe you take egg together with bread, and then you have some salad, cucumber or tomatoes. So that means you have your balanced meal. So as a diabetes patient, of course the cup portion size is very important. So that's why if you see dietitian, so you can visualize. We can visualize how much the carbohydrate portion should you take in a day. Okay.
Just add one more thing.
Yes.
Okay. So sometimes my patients will say, but I don't carry this plate around with me, or I don't necessarily eat from a plate, you know, I might eat from a bowl. So you can always use the handy, what do you call that? Your hand portion size, you know. So anything that gives you your sustained release of carbohydrates, so your rice, your noodles, right? Just eat a fistful, right?
Yes.
Yeah, that is enough. So one fistful, So if you say I've got a very big hands, a big fistful, good for you, okay? Right. So it's there. Okay, 1/4. So that's your carbohydrate needs. Then comes the protein. Okay, you need protein as well. So don't eat like one whole big steak. It's about the size of your palm. Okay, minus the fingers, the palm. So if your chicken or your fish,
It's
right?
about 3 ounces of
3 ounces of meat, to be correct. Let me just put this. This is the meat here, lah. Can you see like that? Okay, jatuh. Okay, right? And then comes to the half the plate. So usually we try to load up with vegetables. Half. They say half means what? Usually it's about two this one. What's this called? Handful lah, like that. Of vegetables. You put it there very nicely. Then for dessert, you have a fruit, a medium-sized fruit. Yeah. So that's one way to figure out how much you can eat.
Yes, thank you. I think that is very helpful for a lot of our patients who may have difficulty estimating portions that they are suitable for them. Before moving on, we actually have a question from an audience about how if it's a patient. Okay, this is a patient with a 63-year-old diabetic patient, and he wants to subscribe to a low carb, no sugar diet. And what do you think of this? If he doesn't want to take any sugar at all, no carb at all, are there any substitutes of carbs that will not spike the sugar?
Okay, just now I say that if we want patient to practice healthy and balanced meal, so means you have all the carbohydrate adequately. So if this patient try to cut down the carbs, low carbohydrate intake, I think that is not suitable for the patient, because if you take less of carbohydrate, less than 130 grams per day, so that's mean your fiber intake, vitamins, mineral will be compromised. So that is not a good idea, because some of the vitamins, if insufficient in your body, so your insulin resistance will go, it's not so good. So your glycemic control also not so good. So that is not a good idea for a diabetic patient to follow the low carbs. And then the sustainability is an issue, because some of patients that practice low carbs maybe cannot afford for long times. Okay, some maybe they do 1-2 weeks and then they back to the normal diet, so that the blood sugar level will maybe go up again.
I agree. I agree. And also, if, for example, if a diabetes patient is taking insulin injections, definitely I don't think it's a good idea to go for a no-carb, sugar-free diet. There's a very high chance of going low blood sugars if that happens, isn't it?
That's right.
Yeah. So, I have another question. If someone doesn't like to eat vegetables at all,
Right.
so can it be replaced by anything?
So maybe I'll try and take that. See, vegetables, when we divide our food into different food groups, the way we do it is one, maybe biologically, of course, but also because the different food groups give you different type of nutrients, right? So if you're going to say, I don't want to eat vegetables at all, and that means you're going to lose out on the nutrients that vegetables give you. So what nutrients do vegetables give you? Fiber, mineral, right? It gives you some vitamins, right? It's a lot of phytonutrients. Phytonutrients are nutrients from plants. So if you cut out your vegetables, they're going to lose out on that nutrients. So I understand that some people don't like vegetables, but remember there are all kinds of vegetables. Okay, vegetables is not just the dark green leafy bitter vegetables. Okay, vegetables come in orange colored carrot, white color radish, mushrooms. Actually, mushrooms is not really a vegetable, but of course a vegetable. You have your cabbage, which is light green. Okay, you have some dark green leafy vegetables. So I would say try the different types of vegetables, and you may find one that you might like. So if you don't like sawi, go for cabbage, okay? But try and fill up your plate with vegetables. You can either cook them or you can have them raw in salads. That's fine. Yeah.
Yeah, I love that. I love that message of trying it. No, don't never say never. You never know, you might find something that you actually like. It's actually very nutritious. Yeah.
That's right. That's right.
Yeah. Okay. What about following questions that we have? Oh yeah, so this is a common issues with, I think, Malaysians in general, and they are busy and they eat out often. Okay, can we still maintain a healthy diet with this?
Okay, I think the answer is yes lah. Okay, you still can control, you still can maintain the healthy diet. The first thing, I think the most important is you need to plan your diet. Plan. Okay, maybe today is Friday, so tomorrow is Saturday, then you try to plan what is the meals you want to take in the next weekdays. That is number one. Number two is you can practice as long as you can practice healthy and balanced meal, you understand how to have a balanced meal. So you can choose outside food. I think outside food also they have healthy choice nowadays. Okay, then you can choose for that. Okay, as long as the portion size is correct, then the meal cooking method is not so much of fat. So I think that's okay.
Yeah, I agree with you, Hazrin. I think we've mentioned this earlier. Key point is to plan ahead. Yeah, Malaysians don't like to plan. They like to do everything impulsively. You know, nampak the char-kway-teow, but the roadside smells so good. Yeah, but you think about always think about where you are going to go. You know, on your work day. What are the options around? Yeah, and you think ahead, and so that you don't fall into a trap of impulsive eating over and over again. Yeah.
Yes, correct.
So it can be like a vicious cycle, isn't it? Yeah.
That's right.
Yeah.
That's right. Because we always sort of go back to our habits, you know.
Hmm.
So I think if you want to try and take action today, think about, I think we're nearing lunchtime. So if you're going to eat out for lunch today, now is a good time. You're not that hungry. Think about, okay, what healthy lunch can I have? Maybe you can write it down, because so that when you reach to that hawker stall or when you open your your food app to order food, you don't impulsively click on the promotional items, right? And you can order that, right?
Yeah.
And don't be afraid to specify your order. I've got patients who say, I'm malu lah, shy, No, you can tell them less noodles, more vegetables. I don't want oil in that, and it's okay, right? Because you're still paying the hawker store owner, right?
Yeah.
So they will still make money and everybody be happy. So don't be afraid to personalize your order for your own health, right?
Correct. At the end of the day, you are in control of your own health,
That's
isn't
right.
it? Yeah.
That's right.
Yeah. I think that's the whole message of our event today, even. Yeah.
Yeah.
Okay. Moving on to the next question. Oh, yeah. I occasionally indulge in my meals, and I have to admit that I'm also guilty of that. And I'm sure 90% of Malaysians are guilty of indulging in our meals, especially, Hari Raya, Deepavali. So yeah, especially for diabetes patients. Yeah. So they say, I'm going to eat a bit more. I know I'm going to eat a bit more today. Can I just increase my insulin dose when I eat more?
Yeah.
Okay, I think most of not most lah, some of patients will do this because they want to enjoy their meals on that time. Maybe they have occasion, so that's why they take this. But this is not a good habit lah. Patients should not do this, because if you take too, as we know, insulin is like a key. Okay, to bring the glucose enter to your cell. So if you take more, then you take insulin more, then you take more calories, then more body fat will be happen lah. So if your fat intake is high, then the body fat intake is high, So it can affect to your glycemic control. So maybe today you do this, maybe vessel unit you now is 6 unit. Maybe the next 1 to 2 years, maybe 6 unit is not enough for you because you do body fat is higher. Okay, so that's why I'm not recommend patient to do this. Okay, but I think some of patients will try to do this well.
Yeah, because we want to eat, right? So I think it's important because in the long run, if you eat too much, okay, you have excess calories, and then excess calories we stored as body fat. Okay, so if you have a lot of body fat, there's something called insulin resistance, like what has been said. It's harder and harder for your cells to use the sugar. Okay, so overeating in the long run makes diabetes control even harder. Okay, so you've got to plan ahead. Remember that. Try not to overeat. Then, like you said, some says, oh, maybe I'm at the buffet or I'm at a wedding party. I want to overeat, so I will adjust my insulin. Theoretically, it's not wrong, but first make sure you know how to estimate in your food how much carbohydrates I'm eating. And so you know how much insulin I'm going to match with the extra carbohydrates. So if you still don't know how to do this well, then let's not play with fire, I would say.
Yes, I agree. So both of you brought up very important points. We see a huge issue with patients on insulin therapy is actually weight gain over time, right? And it's like what Hazrin described, is a vicious cycle. The more you eat, the more insulin you need, and the more insulin you inject, the fatter you get, and then the more you want to eat again. Yeah, so it's a never-ending cycle until at one point you need, like, very, very high doses of insulin already. Yeah, and and I think also because Malaysia has so many public holidays and celebrations lah. You have Deepavali, Hari Raya, Chinese New Year, Thaipusam, everything lah. Yeah, so you kind of have to decide, if you really, really want to binge for one festival, you pick one. Don't go and binge for every single festival. Correct or not?
That's right.
Yes, correct.
Yeah. Okay. What next next question? Oh yes, I think this is a very important question. Quite specific, maybe not for all our audiences, but may be very helpful for type 1 diabetes patients. How should they tailor their diet?
Like the Dr. Lee said, like just now, patient need to know how to calculate the insulin dose based on the carbs they want to take. So make sure as a type 1 diabetes patient, so you must know how to calculate or how you can estimate how much the carbohydrate every portion of your carbs food. So that is number one that you need to know lah. And then you need to know how much the insulin carbohydrate ratio means. If I take 15 grams of carbohydrate, how much dose you need to take? So that you need to know from your doctors, and you can discuss the portion size of meal with your dietitian. Maybe something.
So I quite like that Hazrin mentioned dietitian, doctor, then with diabetes educator as well. I think if you've just been diagnosed with type 1 diabetes, okay, first thing, don't worry, okay? It's not the end of life. It's just something you have. See your doctor, and you usually will have to see more than just your doctor. Okay, you'll see the dietitian, and you also see diabetes educator, maybe a pharmacist, because they are all there to help you then manage type 1 diabetes. Because in type 1 diabetes, your body doesn't produce insulin, right? So you depend on external insulin to help you manage the sugars that come from food. Now, the thing about type 1 diabetes is sometimes when you have type 1 diabetes, it can happen when you're a child or an adolescent, right? So you're still growing. Okay, you may go to school, some are more active, some are less active, right? Sometimes before exam, you're stressed out, or you go on a holiday. So all these different situations will change the way your body uses the insulin and reacts to food, right? So always meet up with your team first, then they will try and match, like say, the food with your medication. And remember that needs as well may change as you grow and in different periods of your life, right?
Yes.
You're living with diabetes.
Yeah, exactly. So it's learning to live with diabetes. So it's not just about the insulin dosages, and learning how to tailor your lifestyle on top of your diet. And it's a whole long journey.
That's right.
I'm sure both of you can attest to the patients you've had these journeys with,
Yeah.
that they take a long time. to slowly get used to it and be familiar and empower themselves
Yes,
with the knowledge and skills to live with diabetes.
that's right.
Yeah.
That's right.
Correct.
Okay. Yeah, we have another question coming in from the live audience. What is your view on ketogenic diet?
So
Yeah.
ketogenic, maybe I'll go.
Okay.
What is ketogenic diet? Ketogenic diet is a diet where you have to decrease the carbohydrates in your diet, so that it's very little, so that you force your body to use ketones. Ketones is a byproduct of fat metabolism for energy. So you don't use glucose for energy, but you use ketones for energy instead. It, like any diet, right? Diet goes through like a cycle, it's like fashion like that. First low protein diet, first high protein diet is fashionable, then low fat diet is fashionable. So I think now it's ketogenic diet and intermittent fasting, right? All right, and after that it'll come back to a different diet, right? Okay. So in ketogenic diet, you're trying to use ketones as energy fuel. So immediately you will see a drop in your sugars. So you might think as somebody with diabetes, hey, this is working. My sugars have gone down. I'm so happy, right? But always then remember, if you have a lot of fat in your diet, right? What sort of fat is it, right? And how is that affecting your other health parameters? Because with diabetes, you need to manage sugars. You also need to manage your cholesterol. You also need to manage your blood pressure, right? And you have to make sure you don't get any side effects. So for example, if I'm on insulin and I suddenly want to put myself on ketogenic diet, then the danger could be hypoglycemia.
Yes.
And that's very dangerous, right? You don't want to be skinny and then after that, be unconscious from hypoglycemia. So in general, we do not recommend that you just start yourself on a ketogenic diet like that. Okay, it can be quite dangerous, right? So again, talk to your friendly dietitians, talk to your friendly doctors, your endos, your diabetes educators. They're there to help you.
Yes, and I think now a lot of our community health clinics also have their own resident dietitians and also specialist nurses who are very familiar with dietary advice that they can give out to patients.
Yeah.
I have another very good question coming in from a live audience. Can you elaborate more about calorie counting? For example, my BMI is 25, my weight is 77 kg. How do I do calorie counting to ensure whether I'm in a calorie deficit for weight loss?
Okay. Okay. So as an Asian population, so the normal BMI is less than 23. So I would recommend for that patient to reduce some weight to get a healthy BMI. So I think a lot of study, even in Malaysia also, study done, which is the calorie recommendation is about 1,500 for the men. Then how 1,500 calories, then you distribute with your meal time. So let's say you have 3 main meals, so you divide by 3. So then every main meal you must have about 500 calories. So then you can estimate how much the portion size of carbs, protein, fat to achieve your 500 calories. Nowadays, it's quite challenged to estimate the calories, but maybe we can use some apps in the phone, some apps such as MyFitnessPal, My Nutri Diaries. Okay, so that is example of apps that you can use to just estimate the calories. Okay, and of course, if you want to losing weight, not only a diet, so of course, physical activity also need to increase.
Yes.
Okay. That's all.
Yeah. Can I just add on
Yeah,
a little
sure.
bit about the use of apps? So very useful. Some of patients do that as well. But make sure you key in the correct serving size. I've had patients who will be like saying, okay, I ate a brownie. I say, my brownie is only 70 calories. I say, you sure or not? Let's say, can you check the size? Then it turns out that the developer put in the smallest brownie size, right? So then when they look, it's actually the largest size.
Yes,
So what you can do is, as you key in the app, okay, and then if you're on a low calorie diet, you should be losing weight. Okay, that is the outcome. Now, if you think I'm already watching my calories, but I'm not losing weight, it means there's something going wrong there. Just bring back your app. Go and see your doctor, see the dietitian and say, I've been following this diet, but I'm not losing weight. What's the problem? Then we will troubleshoot together, and maybe you're estimating serving size wrongly. Maybe you're keying in the wrong calories. Yeah.
Yes.
So that would help.
I think those are the common pitfalls. But before we move on, I would also like to highlight the fact that you need to have your end goal in mind of what are you trying to achieve.
That's right.
Is it what the weight loss for the sake of weight loss, or are you trying to achieve better health overall? We have to remember that BMI is a very crude measure of obesity or of adiposity in general, or how much fat you have. Yeah. So for all you know, you may have very high muscle mass for your height, and because of that, your BMI is 25. Okay, as opposed to someone whose BMI is 22, but with 20%, 30% body fat. Okay, so it's a huge difference in the overall metabolic profile and risk. Yeah. So always think of looking at the big picture. Okay, weight is a very sensitive issue and issue that I think a lot of people deal with, and they always have to think, what are you trying to achieve at the end of the day. Yeah,
I fully agree.
Okay, we have another very good question. So in case diabetes is reversed, I think just now Prof. Lim mentioned, in certain situations, very early on diabetes, and with very, very strict control, they're able to achieve remission of diabetes. Okay, so, and the medications are off. What food should be consumed to maintain blood sugar in the normal range?
Okay, so I think maybe I will answer that question. So I think when Prof. Lim, she spoke about the direct trial, right? So there are a few trials out there that look at what we call lifestyle modification. That means you actually eat to lose weight. I think the key here is to lose weight. You got to lose a lot of weight, and with that big weight reduction, then your body is able then to use sugar or glucose from food in a better way. That's why maybe you can down-dose your medication and things like that. But then these trials, I think so far it's about 2 years, 3 years. Now we do not know what happens after that. So that one we cannot answer. But I would think that having diabetes is not like having a cold, I treat it, it's away. So once you brought the weight down, right, you've got to keep the weight down. Because if the weight starts to climb up again, if your intake starts to go up again, then medications also come back again. You know what I mean? Yeah. So when you start a diet, it's not I start diet, I turn off the diet. It's not like a switch, on off like that. Okay, right? The day I decide that I want to commit to a diet, put in your head, there is no U-turn. I am on the diet track.
Yes.
Important. But remember, if you're driving that diet bus, there are days you feel tired, Ayo, today I'm so frustrated with work. I cannot plan my diet. It's okay, stop the bus for a while, sit down, then maybe you have your chocolate a little bit. Okay, then don't give up. Then after this, okay, I had my chocolate, never mind, now I go and exercise, balance it. I get back on the diet bus and I drive it again until you're 90 years old, 95 years old, 99 years old. Yeah.
Yes, agreed, fully agreed. Diet is part of your whole entire lifestyle, but not just a package that you subscribe for a short period of time. So yes, maintain that healthy diet. Initially you have a very restrictive diet, but when you've achieved remission, we will still need to maintain a healthy diet to keep in remission. Okay, right. There is always a chance of rebound and going back into diabetes at the end of the day.
Yes.
Yeah. I think we have one more question that was pre-prepared beforehand. Yeah, I think this is a common query that I get a lot from my patients in clinic actually. Should I take supplements if I'm a diabetes patient? If yes, what sort of supplements are the best for diabetes patients?
Okay, literaturely, okay, okay. We no need to take a supplement. It's not a consensus that say, oh, you take supplement then can improve your glycemic control. There is no evidence to say that, unless you have insufficiency or you have risk of insufficiency. So that depends on doctors lah. So doctor, you need to see doctors, then you see, is it I need the supplement or not? But for glycemic control, so far no supplement that can improve the glycemic control lah.
Okay. I think that's a very excellent answer, and that should answer most of the questions that our patients have. Oh, we have one last question. Okay, is Diet Coke really 0 calories, and all the sugar replacement like equal? Are they really 0 calories as per advertised?
So maybe I'll answer that. I think the best way for you to find out whether that diet, whatever brand name lah, like Diet Coke, or Diet Pepsi, to be fair, put all the brands out there. Do they have calories or not? Go and read the nutrition label. Okay. what they've done is now, I think food manufacturers are also trying to help, right? So you have, Malaysians love to drink your sweet beverage, right? So if you want to replace that with something without sugar to manage your diabetes, sometimes they put in what we call artificial sweeteners. So something that will taste sweet. So sometimes the artificial sweetener that they put in has no calories. So then that drink has no calories. But sometimes the artificial sweetener they put in has some amount of calories. So that drink has some amount of calories. But when you compare, say, a diet beverage versus a regular beverage, it will have less calories, less carbohydrates. That is fine, okay? But what I usually ask my patients to do is to try and fine-tune your taste buds, because it's about getting used to less sweet. So if I replace a sweet drink with an artificial or a diet beverage that is also equally sweet, the next time I go for my majlis and I see a sweet syrup, that is my taste preference, right? So you're not going to solve that habit of drinking sweet drinks. So why don't you try 𝒑𝒂𝒌𝒂𝒓 kurang manis, then suddenly it goes down, teh kosong. It's possible. I've had patients who started off with coffee and now they're on kopi o kosong and they love it. You take about 3 months to get used to a new taste, right? And the next time you offer something sweet to them again, and then when they drink it, they will say, hey, this is too sweet for me, right? A lot of patients have gone through that, right?
Correct.
Yes. So you can actually train your taste buds to prefer something less sweet or not sweet at all.
Yes, excellent answer, Ching-Li. And this is also a question that I have. So are these artificial sweeteners really all that good? Are there any, like udang di sebalik batu, some problems that come with it or not?
Yeah. So maybe I answer as well, okay?
Yeah, sure.
I think one of the common worries is like, does it cause cancer? Is this dangerous? Okay. So it can cause cancer at huge doses. Okay. So by right, at the dose that they put it into the drink, it's safe. It's approved for food. Okay. But I think there are some studies now to show that when you use this sugar replacers, okay, and not all sugar replacers are the same. Some of them actually alter what we call that your gut flora. Your intestine, you've got good bacteria, bad bacteria. It actually affects the gut bacteria, and now they've linked the health of your intestine to diabetes. If you have a healthy gut, you will also have a better glucose management. So it may alter, but for better or for worse, I still am not sure right now. Yeah.
Yeah, so there's something definitely we need to watch out in literature and see what are the long-term effects of artificial sweeteners, seeing that they were fairly new in our food industries in the past few decades. Yeah. So yes, I think we've pretty much covered most of the questions that were submitted to us, and that has been a very lively and interesting session, I must say. Even I have learned quite a bit having this chit-chat session with you guys. And just to summarize everything, so we've gone across multiple points, including I think these are the key points to take home. Plan out what you want to eat, how you want to eat, how much you want to eat, and also how the food is prepared. All these are important things, but the key point is to plan out and think of the long term of what you want to achieve, and also think of the diet bus. So you can go down for a while, come back up, continue. It's a long haul bus. Okay, there's the only bus ride you have. You don't have a second ticket. Okay,
that's right.
If your bus crashes, that's it. Okay, and also we've had chats about how supplements may be helpful and what type of diet and whether to which sort of diet may or may not be suitable. Okay, and I think this has been a very good session, and let me just thank both of you again. Thank you for coming all the way. Thank you for taking off your Friday morning to be with us today. And before you leave, I just want to give you all just a token of appreciation.
Okay, thank you.
Thank you.
And thanks to our viewers out there.
Bye.
Okay, done.
I didn't mention about we will have a short 5-minute break. We will be back in 5 minutes. Please stay tuned.
Insulin was introduced to the world. In 1922, at the University of Toronto, the scientists went to a hospital ward full of diabetic children, most of them comatose and dying from diabetic ketoacidosis. This is known as one of medicine's most incredible moments. Imagine a room full of parents sitting at the bedside, waiting for the inevitable death of their child. The scientists went from bed to bed and injected the children with the new purified extract, insulin. As they began to inject the last comatose child, the first child injected began to awaken. Then, one by one, all the children awoke from their diabetic comas. A room of death and gloom became a place of joy and hope. Thanks, Dr. Banting and Dr. Best.
The key to a healthy Ramadan with diabetes is knowing your risk. Consult your doctor and speak to your local imam for more information.
Hi, my name's Sergio, and I've been living with diabetes for 10 years. I work with my healthcare team to manage my diabetes. Dr. Manzi is part of my team, and we regularly discuss diabetes management together.
Hi, I'm part of Sergio's healthcare team. Sergio's been living with diabetes for some time now and doing well. I know he has some advice he wants to share.
Thanks, Dr. Manzi. It's not been easy living with diabetes, but one thing I have learned is that it's important to keep track of how diabetes is affecting my eyes. I know now that if I get my eyes checked regularly, we can detect potential changes early, and this is obviously important. With everything I have to take care of, I can't imagine losing my vision, even a little. There are 3 things we can do for ourselves to help prevent eye conditions from developing. 1. Ask our diabetes doctor or eye specialist about our risk of diabetic eye disease. 2. Keep optimal control of our blood glucose and blood pressure. And 3. Regularly visit an eye specialist to have our eyes checked.
1 in 3 people with diabetes will develop an eye condition called diabetic retinopathy in their lifetime. Diabetic retinopathy occurs as a result of high blood glucose levels, which in turn may cause damage to the small blood vessels in the back of your eye. If left untreated, it can lead to vision loss. Diabetic retinopathy is the leading cause of blindness in working-age adults. However, if you catch it early, you can largely prevent vision loss. The longer you leave it undetected, the worse it could get.
A huge part of my life relies on good vision. I can't imagine losing the ability to drive, read, use a computer, and recognize people. And so, with Dr. Manzi's support, I made an appointment with my ophthalmologist for an eye exam. It doesn't take a lot of time, and for most people is completely painless. Now I feel reassured, knowing that my eyes are in good health.
If you're living with diabetes, get your eyes checked regularly. It's recommended that those with type 1 diabetes be screened at least every 1 to 2 years, starting 5 years after the onset of diabetes, and that those with type 2 diabetes be screened at the time of diagnosis, and then at least every 1 to 2 years thereafter. With this approach, your healthcare team can help you catch any changes in your eyes early and offer treatment to protect your vision if needed.
Now I have my eyes checked every year, so I can continue to see what really matters to me. I encourage all people with diabetes to be proactive. Talk to your doctor about your eye health, and don't forget to get your eyes screened on a regular basis. Eye screening saves sight.
For more information about eye health, visit www.idf.org/eyehealth, www.hollows.org, and nowiknow.com.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Welcome back everyone from our short break. Let's move on to our next session. My name is Dr. 𝒂𝒏𝒂𝒓 𝒂𝒏𝒂𝒂𝒓. I am one of the medical officer in medical department in UMMC. The topic of our session now is injection technique. Are you doing it right? Here with us again is our very experienced staff nurse in diabetic care, staff nurse Sharmila binti Abdul Ghafur. Welcome back, Staff Nurse Sharmila. Okay, without further ado, let us watch a very short video regarding injection technique. While we watch, you can send in your question and we will discuss it during our Q&A session after the end of the video.
Segmen ini akan menunjukkan cara pemberian dan penyimpanan insulin. Pertama, cara masukkan kartridge insulin. Buka penutup insulin diikuti dengan pemegang kartridge. Jika rod piston terkeluar, masukkannya kembali. Sekarang, kartridge baru boleh dimasukkan ke dalam tiub pemegang. Kemudian, tutup semula pemegang kartridge. Jangan lupa pusing dan ketatkan sehingga bunyi klik. Jika insulin anda keruh, goyang insulin perlahan-lahan sehingga 20 kali seperti ini. Perlu diingatkan, jangan goncang terlalu kuat untuk mengelakkan insulin berbuih dan kerosakan kepada kartridge. Sekarang, cara pemasangan jarum. Masukkan jarum yang baru dibuka ke dalam pen dan pusing ikut arah jam sehingga ketat. Penutup luar itu simpan dahulu ya, tetapi penutup kecil ini boleh dibuang. Jangan risau kalau ada sedikit titisan insulin, ini adalah normal. Bahagian ini khas untuk nombor pen. Bila dapat kartridge yang baru, periksa aliran insulin dahulu. Tarik dan putar butang dos sehingga 2 unit. Selepas itu, halakan jarum ke atas dan tekan butang dos sehingga angka kosong. Pastikan ada insulin keluar di hujung jarum. Jika tiada, kena ulang semula ya. Untuk memilih dos, anda perlu tarik butang dahulu. Kemudian, pusing sehingga dos yang anda perlukan. Dos ini boleh dilaraskan jika terlebih atau terkurang. Sebelum insulin diberikan, bersihkan kulit dengan alkohol swab. Picit kulit di perut menggunakan 3 jari sahaja untuk dapatkan lapisan lemak. Pegang pen dengan tangan yang dominan dan semak dos yang akan diberikan. Kemudian, suntikkan jarum secara 90 darjah ke dalam kulit. Setelah disuntik, tekan butang dos sehingga menjadi angka kosong dan ada klik. Selepas dos ditekan, kekalkan jarum dalam kulit sehingga kiraan 10. Selepas itu, barulah keluarkan jarum tadi. Selepas suntikkan, ambil penutup luar tadi dan tutup jarum sehingga ketat. Sekarang, pusingkan penutup jarum ke arah lawan jam dan tanggalkan sepenuhnya dari pen. Akhir sekali, tutup pen insulin dengan penutupnya. Insulin pen ini boleh disimpan di tempat yang gelap dan mempunyai suhu bilik kurang dari 30 darjah. Ada beberapa perkara yang perlu diingatkan. Pertama, jangan simpan pen dengan jarum sekali. Jangan bekukan insulin. Sentiasa tengok tarikh luput kartridge insulin. Pastikan pen sentiasa ditutup bila tidak digunakan. Jarum perlu ditanggalkan dari pen selepas disuntik. Kartridge insulin yang baru perlu disimpan di dalam peti sejuk. Kartridge insulin yang dah dipakai atau dibuka boleh disimpan di tempat gelap dan suhu bilik kurang dari 30 darjah. Jangan letak di bawah matahari ya. Jarum perlu dibuang secara selamat menggunakan sharp bin. Jika tiada, letak jarum di dalam bekas keras dan kemudian masukkan ke dalam plastik yang dilabel jarum sebelum dibuang dalam tong sampah biasa. Kawasan suntikan boleh dibahagikan kepada 4 bahagian. Setiap minggu, suntik di satu kawasan dan tukar ke kawasan lain pada minggu seterusnya secara berpusingan. Ini adalah untuk mengelakkan lipohypertrophy. Setiap suntikan mestilah dijarakkan sekurang-kurangnya 1,5 inci dari kawasan suntikan sebelumnya. Jarum ada beberapa saiz. Ini termasuk saiz 4, 5 dan 6 mm. Pemilihan saiz jarum pula adalah berdasarkan berat pesakit, ukuran BMI dan jumlah dos yang perlu diberikan. Saiz yang sesuai akan ditentukan oleh jururawat anda. Pesanan terakhir kami, jangan menggunakan jarum yang telah dipakai. Jarum perlu digunakan sekali sahaja. Jarum terpakai boleh menyebabkan kesakitan, perdarahan dan lebam di kawasan suntikan. Ingat ya.
That was a very short and comprehensive video. Okay, Stana Shamila, we already have few questions over here from our audience. Hopefully you can answer as many questions as possible.
Yes.
First question, does it bleed after injection?
Well, there's a tendency of bleeding after the injection. Why? Because there are lots of blood vessels in our abdomen. So in case if let's say you have hit the blood vessel, then it's fine. It's not going to cause you any much bleeding. So just take a cotton ball or gauze, compress onto your abdomen side at your injection site, and it will stop immediately. So not to worry much. Thank you, Dr. Isan.
Okay, so normally it will not bleed so much.
It will not bleed so much, yes.
Okay. So is it really necessary for us to hold for at least 10 seconds after we inject the insulin?
Yes, this is a very good question. Actually, most of my patients, what they do after their injection, normally what I would ask, do you hold for 10 seconds after the injection? The common answers that I would get back is no. After the injection, immediately they will take out the needle. By right, once you have injected into your abdomen, you have to hold for 10 seconds, or you can even hold longer than that for 20 or 30 seconds for the absorption into your fatty area. So it's better to hold your needle for 10 seconds, then only you take out the needle.
So is there anything that they can see if they were to remove it earlier than 10 seconds? Will there be like any leaking more prominent or anything?
Yes, if at all you are going to take out the needle less than 10 seconds or immediately after the injection, definitely it's going to leak out the medication at the tip of the needle. So it will be a medication wastage, and maybe it won't be accurate. So let's say you are injecting 10 units. So most probably, let's say it has already leaked out most of the medicine actually at the tip. So it's not, the absorption won't be there. So your sugar level will not come down. It will not help with your sugar reading.
Yeah.
So for those who are on insulin, once you have already injected, it's better for you to hold 10 seconds or more, then only you remove the needle.
Yeah, okay, all right. So what happened if a person use the same needle many times, like, few times, and they keep injecting at the same place over the abdomen for few times during the injection?
This is what we face most of the time. This is a common problem from the patients. Almost 70 to 80% what we receive. Okay, for my patients, normally I would advise use the needle once, but sometimes due to the cost and everything, we give choices. You can reuse the needle, but not so many times. Some of my patients, they will use the needle, one needle for one cartridge. It's not advisable, it's not recommended. The most you can go is 3 times a day. 3 times a day, that's the most, because if you're going to use the same needle again and again, it's going to cause you pain at the abdominal side. One thing, and then it's going to cause you hypertrophy. There's a bulging or bumpy side at your abdomen. So there's no absorption. There's no way your sugar reading is going to come down. So, and another thing is you have to rotate. Your injection site needs to be rotated. Every injection site, you have to have at least 1 finger gap between the injections. So this will help you to prevent from hypertrophy and pain from at your abdominal side.
Yeah. Okay. Some of my patient doesn't seem to remove the needle after the injection. Will that cause any problem?
Okay, this is a common problem also that we face. Okay, once you have given the injection, it is advisable and recommended to remove the needle. Why? If at all you leave the needle together with your pen, obviously it's going to leak out the medicine, one thing. Secondly, it's going to cause bubble. And thirdly, it's going to block your needle. If let's say for those who are using the needles for more than once, it's going to block the needle. What happens is the liquid will crystallize at the end of the needle, at the tip of the needle. So the next injection that you're giving, it's not going to absorb. So you'll have difficulty in pressing the pen actually in order to push out the medicine. So it is recommended and advisable after every injection, you have to remove the needle and keep it separate from the pen.
Okay. Okay, for those patients who are on a cloudy type of insulin, for example, mixed-type or insulatide, so what happens if they don't tilt the medication, and will that affect the sugar reading?
Definitely, it will affect the sugar reading. Okay, this is one of the steps, actually, one of the technique. Let's say you have 10 steps. In my opinion, if one of your steps goes wrong, it will spoil whole the technique, and it will not help with your sugar reading. It will not help to bring down your sugar reading. So try to follow the steps as much as possible. You have to tilt the medication for cloudy types of insulin. And the tilting matters. You don't tilt very hard or very fast. You have to do it slowly and gently so that it doesn't cause any bubble while tilting. Okay. So it is important to tilt it according to the steps actually.
Okay, all right. Okay, this is quite a common situation. Sometimes patients are quite busy during their work or doing house chores, and then they may unintentionally taken their meal before injecting their insulin. And only after they have completed their meal, then only they remember, oh, I forgot to inject my insulin. So what would your advice be in this kind of situation?
Okay, for this kind of patient, try not to skip your injections. Yeah, try not to skip your injections. Okay, let's say maybe once in a while you have already taken your meal without the injection. Okay, let's say while eating, if you remember to give the insulin, if you remember, oh, I've taken my meal, but then I haven't given my injection yet. While eating, you can still give the injection. But let's say you have finished your meal, it's already 1 hour. If you realize that you haven't given the injection within an hour, within 1 hour, you can still give your injection. But let's say you have eaten your meal and it's like few hours later on, 2 or 3 or 4 hours later on, I think the best way is you skip your injection.
Okay.
So you'll proceed with your next injection during your mealtime later on.
Okay. Especially among the housewife, they do a lot of housework.
Housework, yes.
And by the time, or cooking for the family for dinner, and by the time they finish cooking, it's already time for meal, and they notice, oh, I forgot to inject like half an hour before the meal. So yeah, so sometimes the timing would be very difficult for them.
Yes, try to keep up with the timing because insulin needs time to function in your body. So as much as possible, try to maintain your timing, which is half an hour.
Okay, all right. So, okay, another common question is nowadays, people are very, they travel a lot. And then some people, they travel for 4 or 5 days. So how would your advice be for these people to keep their insulin correctly and safely?
Okay, I have received this kind of questions actually mainly from my patients who are Grab drivers and also lorry drivers. Okay, how do I store my insulin? How do I store my pen while traveling? Okay, first of all, it's either whether you're traveling here or whether you're traveling abroad, let's say. Okay, first of all, I would advise get a letter from your doctor if you're traveling abroad. That is the first thing that you should do. Secondly, try to make sure you have enough insulin throughout your journey. If you have already planned your trip, make sure you have enough insulin throughout your journey so that you don't have problem later on. Okay, thirdly, how you want to store your insulin while traveling, you have to get a cooler bag with ice packs and also with a thermometer. So you have to maintain the temperature between 2 to 8 degrees. Why? Because from the pharmacy, when you get the medication, normally you will store it inside the cooler bag, and once you have reached home, you will place it inside your fridge. So when you want to take it out and you want to travel, you have to maintain the temperature. We don't want the insulin to spoil, so we have to maintain the temperature. So that is why important you have to get the cooler bag ready, even from the time you collect the medicine from the pharmacy itself. So just prepare with your cooler bag together with some ice packs, 2 or 3 packs of ice, and also with a thermometer. That's how you store it. It will maintain and protect it from sunlight and everything. But once you have started using your insulin and you have already used, the cartridge is already inside the pan, it's already filled in, it doesn't matter. You can keep it outside under room temperature as long as it doesn't reach the sun or anywhere heat. Where it can cause damage to the insulin cartridge. So this is how you prepare yourself before you go traveling, Chilim. And also make sure you have your prescription with you in case if, let's say, you are lacking in insulin cartridge or anything, make sure you have your prescription as well with you.
So it is important for everyone to remember not to keep your insulin inside the car, especially under the sunlight when they leave the car, I think that will wrap up our session. Is there any final advice you want to give to our patient before we wrap up?
Okay, you have already watched, I'm sure most of us have already watched the video, how to give your injection. And I really hope from now, you are able to do your injection technique well. And this video will be on YouTube. And if you're not able to understand the steps or anything, you can always refer back to the YouTube, or even when you have the pamphlet right together with you in your pen box, you can always refer back to your pamphlet, how you want to follow the correct steps.
Okay, all right. Thank you very much, Dr. Samila.
Thank you, Dr.
So
Ihsan.
hopefully that helps to answer all the questions from the viewer. So I will hand over the microphone to our next moderator, Dr. 𝒑𝒂𝒌𝒂𝒓.
Hi, good morning semua. Okay, I'm Dr. 𝒑𝒂𝒌𝒂𝒓 here, medical officer. Okay, so beside me is Dr. 𝒑𝒂𝒂𝒂𝒓 Ibrahim, our consultant endocrinologist from Diabetes Care Unit UMMC. Today, this session is mainly just live Q&A. You can ask any question you want, although the topic is common issues with insulin therapy, but just put down your question. We'll try to address it within our time limit. So, okay. So for first question, okay, Dr. Loman, this is all the question from the live earlier on. Can type 1 diabetes patient, can people living with type 1 diabetes eventually free from insulin injection?
Okay, I'm going to take this answer I'm going to answer this question in a very, very short answer. The answer is no, except in a very special circumstances where you undergo transplantation, either a beta cell transplantation or a pancreas transplantation. Yeah. Currently, transplantation is reserved as the end stage treatment for type 1 diabetes. So most of the time, in most guidelines around the world now, we go for optimizing insulin therapy rather than looking at that option. Except for in some circumstances where some patients, they might get end-stage kidney failure, for example, where they are listed for kidney transplantation. So in those circumstances, one might consider a kidney pancreas transplantation, and that might induce a diabetes remission.
Yeah. So that patient, that question actually comes back to all the reason behind why you become a type 1 diabetes versus a type 2 diabetes, which is actually different in the way the disease progress and yeah. So we have a few more questions regarding the types of diabetes. So one more question: can people with insulin resistance become a diabetes?
Yes, insulin resistance is one of the underlying defect in type 2 diabetes. Insulin resistance often comes with increasing body weight. It often comes with increasing age. It often comes with other comorbidities like inflammatory disease, for example, like chronic infection, HIV, sometimes autoimmune disease like rheumatoid arthritis, for example. Insulin resistance can also come with medication. So, for example, like with glucocorticoid. So yes, this insulin resistance is one of the mechanism that can lead towards the development of diabetes. Not all patients with insulin resistance can develop diabetes, but it is certainly a risk factor. So when combined with other risk factors, yes, it does certainly increase your risk of developing diabetes.
Okay, so next up question is almost the similar question. This is about, I think it's type 2 diabetes. So this participant is asking about if my mom is having diabetes for almost 18 years, okay, and she's on insulin mixed injection twice a day, and now she's doing like she have a diet plan like we say just now, the low carb diet, and in hope to stop insulin in 1 fine day. So can we discuss this question for type 2 diabetes patient is if once they are on insulin and at once diabetes as at almost 18 years of diabetes, is there any chance that they can actually stop insulin at all?
Okay.
Yeah.
As we have discussed earlier, insulin resistance is one of the mechanisms for development for type 2 diabetes, but there are also other multiple mechanisms on how and why a patient develops type 2 diabetes. Often this mechanism works in tandem, so they work at the same time. Multiple mechanisms work at the same time. One of the important mechanisms that happens in almost all patients with type 2 diabetes is beta cell depletion, meaning that their insulin cell, beta cell is the insulin producing cell, right? It begins to deplete over time. And this process happens even before a person is diagnosed with type 2 diabetes as well. So the prevailing theory is that when you have insulin resistance, assuming your beta cell is intact, your beta cell should be able to overcome insulin resistance. But the moment that your glucose starts to go high, it means that your beta cell is not able to overcome the insulin resistance. And this implies that even at the very onset of type 2 diabetes itself, there is already a beta cell defect. And beta cell defect progresses throughout the duration of type 2 diabetes. So often in patients with long-standing diabetes, their beta cell does not produce enough insulin for medications to work. So for this patient, they will require additional insulin injection. Although not like in type 1, the insulin does not has to be that is not as complicated as type 1 diabetes, but they still need that supplemental insulin somehow. Often they require in the form of basal or mixed insulin or more complicated injection. With the idea that can we stop insulin by dietary modification, I feel that this is a bit of a dangerous idea because knowing that how diabetes progress, right, that the beta cell depletes over time, yes, in theory, if let's say there is some residual beta cell reserve, one might be able to stop insulin with dietary modification. But my feeling is that this is often temporary. So it means this is not a permanent cessation or this is not a permanent stop for insulin therapy. So often in a short time, maybe in a few months or in a few years' time, the person will need to start back on insulin therapy. So my approach often in my patient is that yes, if they want to modify their diet, if they can lose weight, I would go in support of that. If there are other non-insulin therapy or other non-insulin options, for example, like tablets, SGLT2 inhibitors, GLP-1 receptor agonists that can be used instead of insulin, I personally tend to gravitate towards that. But if a patient requires insulin, I will not hesitate to start them on insulin.
Yeah, thank you, Dr. Roman. I think the conclusion to this answer is you have to be like personalized. Everyone's is a little different. All people living with diabetes, they are all different at different stage of their beta cell function level. Some may be 0, some may be 50, some may be 20. So you really have to discuss with your doctor regarding whether there's any possibility that you can off insulin and Gandhi with other medication, and always continue with your diet plan Yeah, and actually insulin, as we all know, is the longest medication assist in the diabetes management, is and actually a very safe medication without a lot of side effect. Yeah, so okay. So can we move on to the next question? So Dr. Luqman, can you tell us what's the difference between basal and prandial insulin, and how many types of insulin are there in general? Yeah.
I think insulin treatment is an interesting, is a long topic, is a big topic. Despite 100 years of us using insulin already, I think insulin treatment is still something that we still need to fine tune, we still need to study, we still need to learn more about it. Mainly because of two reasons. Number one is that insulin is a what we call is a treatment, is a biological product, is a treatment with what we call as a narrow therapeutic index. So meaning that when it has narrow therapeutic index, the difference between the effective dose and the toxic dose, meaning i.e. the dose that can cause hypoglycemia, is quite narrow. So we are talking about within 10%, 20% range like that. So we need to be able to fine tune our insulin. So because of that, I think the other reason is because of hypoglycemia. So because we want to avoid hypoglycemia, because we know that hypoglycemia can increase risk for mortality, increase risk for cardiovascular event in people with diabetes. So because of that, I think for us it's important to learn, to know and to educate patients and healthcare providers alike about using insulin and the biology behind insulin itself. So back to the question, what are the different types of insulin do we have? I think this is one of the more fundamental questions that we tend to teach patients and our healthcare providers alike. We have, if you look at our beta cell, it works in two ways. One is that it will produce a baseline secretion. A baseline secretion means that is a insulin production that occurs throughout the day, regardless of whatever we do. We can be sleeping, we can be resting, we can be exercising, we can do other things as well, but the beta cell will continue to produce this baseline level of insulin. And then when we eat, right, when we take carbohydrate, then the beta cell will produce additional amount of insulin. So these are what we call as a mealtime insulin or prandial insulin. So when we talk about insulin treatment, most of the time we try to mimic these two types of pattern, meaning that we have a baseline insulin, or we call it as a basal insulin, and a mealtime insulin. The typical basal insulin that we use includes brands like Insulatard, Glargine, Lantus, Toujeo, and Detamir, whereas the usual prandial insulin or mealtime insulin that we use includes Agrapid, Novorapid, Humalog, as well as Apidra. But there are also mixed types of insulin where manufacturers mix both basal insulin and meal insulin, and this can be found in the forms of Mixtard, Humalog mix, as well as Novomix. These mixed insulin are generally used for people with type 2 diabetes because they are not as customizable as a separate dosing. It depends on some patients, they might require simpler insulin dosing. Some patients, they might require more complicated insulin dosing. But I think it's important to understand that a person with diabetes will generally, once their beta cell is not functioning enough, right, they will need basal insulin throughout the day, whether they eat or not. Yeah, so it means that they will need meal insulin when they eat, but when they are not eating, they will still need basal insulin to maintain glucose level within normal range.
Okay, can. So I have one more question here regarding Mixtard. We have an audience asking that, is it normal that when I wake up in the morning, my fasting blood sugar is around 4 to 5, but after I eat around like maybe 2 hours, it's 8 to 10 with insulin Mixtard injection? Maybe Dr. Luqman can explain on that. Yeah.
So remember that when we talk about Mixtard, we are referring to that mixed type of insulin. So this is a mixed type where they have a basal component as well as they have a mealtime component. Okay, and this mixed insulin, they come in a fixed ratio. So because it comes, typically they comes in a 70% basal insulin and 30% meal insulin. So because of the fixed ratio, right, it comes in the assumption that everyone eats the same. So it means everyone eat the same amount of food, and therefore for a given person with a certain insulin requirement, you will need that much of meal insulin. But of course, while this applies to most people who eat within acceptable error margin of that assumption, there are some patients who eat very differently from the common assumption. There are some people who eat very little carbohydrate. There are some people who eat more than the average amount of carbohydrate. So for these people, that assumption that there is a 30-70 ratio of meal time insulin as compared to basal insulin, this assumption might not apply. So in the question that was put forward, what happened was that the person gets hyperglycemia or high glucose after a meal, and this is despite what sounds like an adequate basal insulin, which means that fasting glucose is normal, but the postprandial glucose is high. So this is most likely because of above average carbohydrate intake. We are not implying that this is exactly a bad thing. I'm just saying that this treatment might not be suitable for that kind of eating pattern. So there are two ways to do this. One is that, of course, change the eating pattern, so means take less carbohydrate. But changing eating pattern for many patients, it might be a bit more difficult because they are quite used to take that amount of carbohydrate. Another way to do this is actually to talk to your doctor, because there are other different ratios of premixed insulin. For example, like we have 50-50 insulin as well. And the other options, we can split the basal and the prandial insulin. So these are a few options that we can use to address the problem that was addressed was put forward in the question.
Okay, thank you, Dr. Lokman. Okay, so next question, we want to discuss about, I think you might have a lot of experience counseling patients who are, fear to start insulin after they have like long-standing diabetes, or the blood result shows that they already start needing insulin as their beta cell function reserve is quite low. So how do you actually counsel this patient, or how do you handle this problem? Yeah.
Okay. Thanks for the question. This is what we typically refer to as treatment inertia. Treatment inertia means that the reluctance to progress forward with treatment of diabetes. As we know, diabetes is a progressive disease, and therefore treatment for diabetes should, in theory, be progressive as well. So it means from one treatment, you should progress to other forms of treatment as the disease progresses. But often we encounter this problem with treatment inertia, means that there's a reluctance to progress to the next step of treatment or to the next stage of treatment. For example, in a person who requires tablet, right? When they combine 2 different tablets, 3 different tablets, but this is still not enough, they might require insulin, but there's a reluctance for them to proceed towards insulin therapy. Treatment inertia is multifactorial, means there's a lot of reason why people get treatment inertia. It can be because of a patient factor. It can also be because of a doctor factor. So, and a lot of the time is not always the patient. Like what we always assume that patient refuse treatment initiation or refuse insulin injection. A lot of time it's not 100% their problem. To a certain extent, there's also healthcare provider. Maybe we are not trained enough to promote the idea to progress with treatment. And maybe there's a lack of trust between the patient and the healthcare provider. For example, like if let's say today a patient come and see me and then I tell them you have to start injecting insulin, right? If the person is not familiar with me, they might want a second opinion. For example, they might want to see, why do I ask another doctor and see whether do I really need insulin? Is there any other type of treatment that I can take instead of insulin? Whereas if let's say I've built a trust with the patient for a long time, then that might be something that easier for me to convince the patient to progress with their diabetes treatment. There's also an interesting finding in a recent study that shows that patients who are counseled by doctors and who are counseled by pharmacists and nurses, right? They found that patients who are counseled by pharmacists and nurses tends to progress better. So it means nurses and pharmacists are better at overcoming treatment inertia as compared to doctors themselves. So I think this implies an important role for a multidisciplinary care for people with diabetes, and for them to meet regularly with their nurses, with their diabetes educators, with the dietitian and with pharmacists, instead of just meeting their doctors and discuss about where their treatment progression should be. Yeah. Of course, at the same time as well, I think we have to remember that different people have different stages of life. So we see people from all stages of life, for all stages of all levels of society. So different levels have different motivations, they have different priorities, they have different needs at different stages of life. So I think it's important for us healthcare providers to recognize that. For example, if I were to ask a student who's going to sit for exam next week, for example, to start insulin injection, right? But hell no, the student is not going to start insulin right before the exam, because I think that's really quite an inappropriate time to talk about treatment intensification. So I think this is something that we need to put in mind as well, that different people, if you tell them to start insulin today, if they are not keen to start, maybe they will change their mind later in the future. So it's important for us to keep engaging them and keep talking to them and advise the idea for treatment intensification.
Yeah. Thank you, Dr. Luman, for the answer. I think the key point is really sometimes we always assume patient is the one that fear about insulin, but sometimes the fear comes from healthcare worker that initially diagnose, and then we counsel patient regarding diet and everything, and we create fear by telling them if you don't control now, later you are going to start insulin injection. But you have to actually understand that diabetes progress despite you are on a full diet plan. Sometimes your beta cell function just decline,
and despite the best treatment and despite the best control, also diabetes will still progress. So it's not true that if you don't control diabetes, you will require insulin treatment.
Yes. So for all the people living with diabetes out there, if your doctor tell you need to escalate your treatment, don't feel that you are a failure. It's just a part of diabetes that it would actually progress, and eventually at some point after a few years of diabetes, especially type 2, you might need insulin. Might or might not need insulin, but it's not that when you're starting insulin, you are a failure. It's not something like that. I think all doctors have to understand this concept and not scolding your patient every time you see the H1C go up, because it will go up.
Yeah, true.
Yeah, okay, sure. So we move on to the next question. Can Dr. Luman explain to us more about hypoglycemia if for people living with diabetes on insulin?
Okay. Hypoglycemia is the main major barrier with insulin therapy. In fact, a lot of the time treatment in Asia with insulin therapy, why people fear to start insulin, why people fear to intensify insulin, is because of the risk of hypoglycemia. And when we talk about the risk of hypoglycemia, it is important for us to address this issue or the risk of hypoglycemia even before the patient develops hypoglycemia itself in the first place. So not after patient develops hypoglycemia only you teach them, but even before that. So when we start them on drugs that can potentially cause hypoglycemia, for example, when we start them on sulfonylurea, when we start them on insulin, at that time we already need to teach them about the risk of hypoglycemia and teach them how to identify the symptoms of hypoglycemia, how to diagnose hypoglycemia, as well as how to treat hypoglycemia, and who to talk to when they develop hypoglycemia. So these are important issues, or these are important contents or knowledge that we need to teach patients when we start them on this treatment, especially so when they do actually develop hypoglycemia itself. Of course, yes, we do have hypoglycemia training material in our diabetes care unit. Typically, we advise them this 15-15 method, whereas a person initially checks blood glucose first and to confirm whether their glucose is less than 3.9, and then they ingest 15 grams of fast-acting carbohydrate, and then repeat the blood test again or the glucose test again in 15 minutes time to make sure that it does indeed goes above 3.9 millimole per liter. But I still advise that all patients who develop hypoglycemia to talk to your diabetes care provider, because often hypoglycemia has identifiable cause. So often hypoglycemia is caused by either because you're not feeling well, because you're not eating enough, or maybe because your treatment is just too much. Then maybe you just need a different type of treatment. Maybe you just need some revision on your treatment. So I advise that all patients who develops hypoglycemia to talk to a diabetes care provider as soon as reasonably possible. Yeah. Of course, if you develop severe hypoglycemia, a patient goes into coma, that would need emergency treatment. But short of that, most patients, they have mild hypoglycemia. So these are issues that we need to address as soon as possible.
Okay. So I have one question here from the live audience. Okay. So this audience is asking, I am hypo-prone and hypo-unawareness. I suppose she's on insulin, and she said, I go to bed with a sugar reading of 6. And she wake up in the morning, the sugar level actually spike up to 16. So do I increase my basal, or do I do correction for the prandial insulin when I wake up?
Okay. Thanks for the question. Number one is that because since this is a public channel, right? I cannot give specific medical advice, so I will refrain myself from doing that. Well, I can say that there are a few reasons why a person might develop that. There could be because they develop hypoglycemia at night. It could be because of their hormones that are being produced early morning. We call it as a dawn phenomenon. But then again, a person who are hypoprone, they might even get hypoglycemia at other times in the day, not just at night, but also during daytime as well. So this typically happens in patients with type 1 diabetes, but it can also happen in patients with long-standing type 2 diabetes as well. My best advice for this, the person who asked this question, is to talk to your diabetes care provider. Yeah, because now we have new technologies that can detect hypoglycemia even when you are sleeping, even when you're not checking your blood glucose. We can arrange a glucose, continuous glucose monitor, or sometimes we call it as a glucose sensor. Some of this model can come with an alarm system as well, so you will know when you get hypoglycemia. The system will alarm you. Even when you're sleeping, also it will alarm you when you get hypoglycemia. So my advice, talk to your doctor and find out what system works for you. And of course, treatment modification when possible should be done, and this can only be done by a diabetes care provider. So my advice is still talk to your diabetes care provider to address this problem.
Okay, so we have another question that goes back to what we have always have been discussing for quite some time. So it's about diabetes remission and when should we stop medication. So this audience is asking about what are the benchmarks for doctor to reduce or off the medication. Is it looking at HbA1c reading or any other indicator?
Yep. Usually when we talk about diabetes remission, we are talking about type 2 diabetes rather than type 1 diabetes lah. Yeah.
Yep.
When we talk about type 2 diabetes, we are talking about HbA1c of less than 6.5. Without medication. So meaning that if let's say the HbA1c is well less than 6.5, I'm getting HbA1c of 5.6, for example, or 5.8 on a patient with a triple medication, then it is safe for me to withdraw one medication and repeat the HbA1c again. If it still remain well less than 6.5, I can withdraw another medication and then we see how it goes. So if let's say it is possible to withdraw all medication and the HbA1c remains less than 6.5, then this patient is considered to have diabetes remission. Yeah, but the concept of diabetes remission, I would say, is still experimental concept, because if you look at our standard of care or our standard of treatment now, a person with pre-diabetes, right, can be treated with metformin, or some patient they might require metformin treatment to prevent their progression into type 2 diabetes. So a person with a diabetes remission at the same time, also they are at risk of getting diabetes again. So should they be treated as a person with pre-diabetes, for example? So should we treat a person with diabetes remission as the way we treat a person with pre-diabetes, i.e. should we continue them on metformin? So, and of course there are questions that what about the new diabetes medication? Can they also be used in a patient with pre-diabetes? Can we just continue them with the patient with diabetes remission? I feel that the idea or the decision whether or not one should continue diabetes treatment even with remission, or whether they should stop diabetes treatment after they have achieved remission, this needs to be discussed with their diabetes care provider. Of course, things that need to be taken into consideration will include the cost of treatment, the side effect of medication, as well as the monitoring that is required. So if let's say the treatment has side effect, requires frequent monitoring, and they might not incur additional HbA1c reduction benefit, then it's probably better to stop it. Whereas if let's say the medication is safe, it doesn't require much of monitoring, let's say metformin, for example, it is certainly possible to just continue this medication with the hope, of course not exactly evidence-based yet, not proven yet, that continuing this medication will lower their risk of getting diabetes again or going into a relapse of diabetes.
Thank you, Dr. Loman, for a good overview of how diabetes progress, and this is a common misconception among publics that they feel like they are treated and they can off their medication. So the answer is actually to talk to your doctor. That's why it's very important for you to keep on follow up with your doctors and check your HbA1c level and sugar level from time to time, and always discuss with your doctor and not listening to non-healthcare provider. Yeah. So okay. So we have another question from the audience. Dr. Loman, how do you treat hypo unawareness?
This is a tricky question. The traditional way of treating hypoglycemia unawareness is actually to use to what they call it to relax the glycemic control. So because hypoglycemia unawareness often occurs in patients with type 1 diabetes. Yeah. So the traditional way of treating hypoglycemia unawareness is to relax the diabetes control. So meaning that instead of trying to get HbA1c of less than 7, we try to get HbA1c of less than 8, for example. And that over a few weeks' time will improve their perception towards hypoglycemia, and then it will reverse their hypoglycemia unawareness. But I think we do have better treatment now. Okay, I think with more access to pumps and sensors, there are options that we can offer to patients as well, instead of just simply relaxing their glycemic control, because some patients with type 1 diabetes especially, they can get hypoglycemia unawareness for years. So the question is, do we relax their diabetes glycemic control for years? I do feel that if, let's say, newer technologies are available for this patient, if let's say they can use a closed loop system or a sensor augmented pump, for example, that can suspend insulin delivery when they develop hypoglycemia, despite not being aware of it. I feel this would be a better option for this patient. But of course, these are not treatment that is accessible to everyone. So remember that these are still these are still expensive treatment, and it is certainly our hope in the future that this treatment, these new technologies will be more accessible to all patients, if not for everyone in the future.
Thank you, Dr. Roman. Okay, since we are at the main topic here is about access to diabetes care. So we have one question, I think is posted by a doctor about what the government should do to increase access to all the new medication available like SGLT2, GLP-1RA, and newer and broader generic, new insulins for more patients. Yeah.
Thanks for the question. I think this is a very important question, because one of the issues that IDF, the International Diabetes Federation, try to bring up with the current, this year's theme, access to diabetes care, is really about treatment costs. Yeah, and in some countries, and some treatments still remain expensive and out of reach for most patients, for many patients. And I do feel that there need to be a multi or collaboration between multiple parties to improve access to treatment from government, from regulators, from industry players as well. And ideally, all diabetes treatment should be universally accessible for all patients with diabetes. We know that some countries, they can do this. We know that, for example, in the NHS, for example, they are now introducing closed loop system for patients with diabetes, are funded by the NHS. But of course, in many other countries, this is still not feasible. But I wouldn't feel it is impossible. I feel this requires a lot of political and will from the government and the industry players, as well as from us, from healthcare providers and diabetes advocates, to push for this idea. Remember that not too long ago, right? HIV treatment is not free, but nowadays HIV treatment is free for all. So it is not impossible to push for idea that treatment should be accessible for all patients with diabetes.
Thank you, Dr. Loman, for the concept on universal healthcare coverage. I think we are quite fortunate here in Malaysia, given that, we can just pay RM1 and access to most of the medication available in klinik kesihatan. And while in overseas, some they can't even afford insulin and have to cost to other countries to just buy a cheaper insulin. Yeah, I think we are quite fortunate here, but I think a lot more works need to do to introduce the new medication to our patients so that we can prevent more complication. Yeah.
I agree with that. I also feel that I'm also aware that now our government is engaging more in health economics. studies to decide on or to gauge on what is the best value that they can get for our resource, right, for our budget. And I do feel that this is certainly a move in the right direction. So instead of deciding which drug is better because they are cheaper, or buying which medication, the cheaper medication, I think the decision should be to go for treatment that provides better value. So if it does reduce complication, for example, this might translate to a better value, and this is something that we should consider in.
Yep. Okay, so we move on to our last question due to time limitation. Okay, so we have one question here about how to address challenges in patients who are financially deprived and geographically challenged.
Okay.
Yeah.
Thanks for this question. This relates very closely to our team this year, Access to Diabetes Care. When we talk about lack of access, we are talking about financial access, we are talking about physical access, because of distance, because of time, because of their work and other commitments. And I do feel that as a diabetes care provider, this is where knowing your patient better really helps. Because when you know your patient, you know what are their commitments, what are their financial capacity, what are their time restraints. So if let's say my patient is working, is a single mother working to look after small kids, and at the same time need to work, and at the same time you expect them to come to clinic to regularly follow up their diabetes and their glucose monitoring, I feel this might be a bit too much to us lah. So if let's say some patients who are more resourceful, then it is probably possible for us to offer newer treatments that can have better efficacy and less complication, less hypoglycemia. At the end of the day, it's really about individualization of treatment. Okay. Some patients, they might be able to go for more intensive treatment. Okay, when we say more intensive treatment, it does not mean more dangerous treatment. It means that assuming or with proper monitoring, right, even more intensive treatment can work better with manageable risk of complication or risk of side effect. But in some other patients, they might require less intensive treatment, or they might require a slightly more conservative treatment. But at the same time, we don't allow them to become overtly hyperglycemic or to become overtly uncontrolled. So at the end of the day, I feel that this is where a good relationship between the patient and the diabetes care provider is really paramount. It's really important for us to know about the patient, for us to know what are their lifestyle, what are their restraints, what are their strengths, what are their weakness, and work on that and try to know. Again, at the same time, remember that patients have different motivations at different time of their life. They have different priorities at different time of their life. I had patients whose diabetes was difficult to control 10 years ago, and now they are very motivated to control their diabetes. It does not mean that a patient is difficult, they will remain difficult forever. It just means that we need to give them more time, and we just need to know them better and try to address what do we feel is a limit in our treatment.
Yeah, I agree, Dr. Lokman. I think the most important quality of someone who is taking care of people living with diabetes is to be able to build a good rapport and understand your patient's circumstances, and not just by telling them off or scolding them for not controlling diet. Yeah, and to understand what are the options of medication and discuss it with your patient. Yep. So so we wrap up our session. Thank you, Dr. Lokman. We move on to our next session. We will have Dr. 𝒑𝒂𝒌𝒂𝒓 to talk about COVID and diabetes. Yep.
Thanks, Ingrid.
I'm 𝒑𝒂𝒌𝒂𝒓, Medical Officer in the Department of Internal Medicine, UMMC. Let us move on to the next session of the day, that is diabetes in the new era. Let me introduce the guest of honor who is going to speak for the day, Dr. Lim-Kwan-Ziong, lecturer in the Faculty of Medicine, University Malaya, currently subspecialty in endocrinology and diabetes.
Thank you for the kind introduction, Krinath. Thank you to everyone who are still with us right now. We've been on for around 3 hours plus, and I hope everyone has been having a good time. Can I have my slides on, please? So today I'm going to be talking about diabetes in the age of a pandemic. Now we know that we have COVID since end of 2019 until now, and things have changed so much. So I think it's only apt that we talk about this. But this will be the final talk of the day, actually. So, okay. All right. I need to put on my slides. Okay. Yeah. Okay. So as of November 2021, we know that worldwide we've seen up to 250 million cases globally and 5 million COVID-related deaths. Whereas for diabetes, we know as of now, we have around 537 million adults worldwide who live with diabetes, and 6.7 million deaths worldwide in 2020 were caused by diabetes. This is slightly an underestimation, as sometimes the data is not collected in some underprivileged countries, but the true prevalence may be even higher. So we know that COVID is a communicable disease, an infectious disease, whereas diabetes is a non-communicable disease. But however, this pandemic has shown that there is a huge part of interaction between communicable disease and non-communicable disease, and because of this, this has triggered what we call a COVID diabetes perfect storm. Now, why is it even more pertinent in Malaysia? Because we know that 1 in 5 adult Malaysians are diabetic. That is a huge percentage, and we expect it to be increasing over the next few years. I think just yesterday, our 𝒑𝒂𝒌𝒂𝒓, our Minister of Health, actually have mentioned that our diabetes rates in Malaysia is increasing, and our obesity rates is also on the way up. 1 in 2 Malaysians are either overweight or obese. And a huge proportion of these patients who have diabetes are actually going undiagnosed. And by the time they are diagnosed, they may have already developed some complications from diabetes itself. And a lot of these patients are also young onset type 2 diabetes. So like what Prof. Lim Li-Ling has mentioned earlier on today, that young onset type 2 diabetes is becoming more and more common, and the mean age of onset is becoming younger and younger. And this is a huge issue because patients with young onset diabetes face faster progression of their diabetes to develop complications from diabetes itself. So we will likely be seeing more and more issues with complications of diabetes, such as end-stage renal failure, going dialysis, cardiovascular disease, and stroke in the next few decades. Now, there was a question from the audience when we asked pre-event questions about COVID and diabetes. So I think this has been much publicized in the media, that people with diabetes, we know people with diabetes fare poorer when they are diagnosed with COVID. However, they do not have a higher risk of contracting COVID-19. And this is based on wide level of data that has been collected internationally. We see that there's no increased risk of contracting COVID-19 itself, but rather it is when they contract COVID, the outcome is much poorer. They are more likely to be admitted. Okay, they are 2 to 3 times more likely to be admitted, 2 to 3 times more likely to be admitted to the ICU when they are admitted and requiring mechanical ventilation. So mechanical ventilation is when your COVID is so serious that you cannot breathe on your own, your lungs are unable to process the oxygen, and you need a high oxygen support with a ventilator machine. And also because of that, they are more likely to die from COVID. And also lately, we've been seeing more and more long COVID syndromes. And we do see that amongst diabetes patients, their risk of having long COVID symptoms, such as lethargy, poor appetite, unspecific complaints mainly, and headaches. Okay, so all these symptoms are more common in patients with diabetes. Now, why is diabetes and COVID such a terrible combination? First, we must know that diabetes itself leads to immune dysfunction. So this has been known for, this doesn't just apply to patients with COVID. We have known this for many years, that patients with diabetes generally fare poorer even when they have any other infections. And this is a direct correlation whereby poor diabetes control is linked with poorer outcomes, where we see patients with higher HbA1c is linked with higher mortality. Now, when combined with COVID-19, we know now that COVID-19, the reason it is so deadly is because it triggers an immune reaction. And usually when they have a severe enough immune reaction and they require admission, patients will be treated with steroids. And with treatment of steroids, that itself will also increase the patient's blood sugar levels. And when we know that when in a stressful condition, even without treatment with steroids, the blood glucose will also go up. And blood glucose, when it's increased, we know this is like a vicious cycle of increased blood glucose levels, severe immune dysfunction, and then at the end of the day, this will lead to what we call a cytokine storm, whereby the immune system goes into overdrive in a hyperinflammatory condition that ultimately leads to death. Now, what about the indirect impact of COVID-19 that we may not realize? Okay, I think this has been much highlighted in literature and in the media as well, and we may also realize it in our daily lives. We realize that healthcare systems have been strained to their capacity over the past 1 to 2 years. There has been massive redistribution of resources, so it is not just to patients who have COVID that COVID has affected. So it's patients who have cancer, patients who have poorly controlled diabetes, may have their appointments postponed, and therefore lead to later diagnosis and treatment of their condition, and leading to poor outcomes. Also, there has been change in health-seeking behavior. We do see that some patients think that, I think that's because of the stigma of having to self-isolate at home, not go out of the house. They feel like going to the hospital itself is a risk factor of getting COVID. And because of that, they're missing their appointments. And at the end of the day, their health outcomes actually fare poorer because of that. Also, we see that because of movement restrictions, we have all adopted pretty much a sedentary lifestyles over the past 1 to 2 years. And that itself has led to increased rates of obesity and diabetes. And last but not least, in fact, effect on mental health, okay, is something that is maybe invisible, but very significant, as we all may know. And yes, actually, it is real. Okay, you are not imagining the weight gain you've seen, around us. Patients, people we've all had prolonged lockdowns. We've all had changes in our work patterns. We've been a lot of us have been shifting from working from the office to working from home. Okay, they no longer need to take public transport or walk to office. Yeah, so our lifestyle becomes more sedentary, and also changing in our eating behaviors over the past 2 years. I'm sure food delivery has been at the tip of our fingers, and all this has contributed to weight gain. In fact, a study in the US actually found that people on average gained 1.5 pounds or 0.7 kg per month, okay, during lockdown. You can imagine how many months of lockdown we've had and how many kgs on average people have gained over the past few months. Now, moving on to what's more relevant to our diabetes patient. So if I'm a diabetes patient and I have just tested positive for COVID-19 and I have to self-isolate, what should I do? So number one, keep track of when your symptoms start, as this may help determine your treatment should you need admission later on. Because as you may know, you may or may not know, when the decision to start treatment for COVID-19 depends also on the day of onset and the progression of your disease. You also need to monitor your symptoms, especially for your temperature or your any symptoms of difficulty breathing, and also monitor your oxygen levels. So now the pulse oximetry is very widespread available, and so it has been advised by the government that every household should have at least one pulse oximeter at home during the lockdown period. Now, red flags to watch out for if you're sitting at home, you know you have diabetes and you know you have COVID. So these are the red flags to watch out for, and you know you don't delay, you need to seek help early, is that you have severe lethargy, shortness of breath, chest pain, persistent vomiting or low oxygen levels. Define the SpO2, the oxygen levels of less or equal to 95%. So you have to seek help early if you know that you are a high-risk population. Okay, if you know you're a poorly controlled diabetic, okay, you have heart disease, you're elderly, pregnant women. This is by no means an exhaustive list, okay, but these are examples of patients who are at high risk of developing severe COVID or high risk of dying from COVID. So seek help early. So this may have been difficult earlier on when our healthcare system was very, very strained and we couldn't even accommodate most of the patients that came in. But now as we enter into the endemic phase, do not let our guards down. And if you know that you are at a high risk, even though you are vaccinated, you've completed 2 doses, even 3 doses, if you're unwell, seek help early. Now, lastly but not least, okay, especially if you're quarantining at home with other family members, maintain your universal SOPs. Now, what about the sick day rules of diabetes? Okay, so how do you take care of yourself if you have to self-quarantine at home? You're not sick enough to go to the hospital. So what do you need to do at home? So this is a very general advice for patients with diabetes or even just in general. So number 1, you need to remember to keep well nourished and hydrated. Okay, it's important for your body to have enough nutrients and enough fluids to actually fight the infection. Now, studies have actually shown that some micronutrients, such as zinc, selenium, and vitamin D, have been shown to be helpful in helping the body's immune system to deal with viral infections. This includes COVID-19 infection. Now, when I ask you to drink plenty of water, make sure it's unsweetened drinks, especially if you're diabetic. If you cannot take a lot of food, sometimes the appetite is reduced and COVID causes your taste buds to go funny. So consume small amounts, okay, and frequently. For example, if you cannot drink a whole bottle of water straight away, nobody's forcing you to drink a whole bottle of water. Just take slow sips, maybe 100 ml every hour, every 2 hours or so. Now, if you're diabetic and you're on medications, make sure when you're at home, you have adequate supply of medications. Okay, this was very important previously during our lockdown periods. We were highlighting again and again to our patients, even though it's lockdown period, make sure that you have enough of your medications. If you don't have, please contact us or get the pharmacist to actually send the medications to you if it's available. And in general, patients who are on insulin should not discontinue your insulin. Okay. This is because if you stop your insulin, your sugars may actually go very high up to very dangerous levels, and you may end up coming to the emergency or admitted to the hospital with diabetes emergency such as DKA or HHS. If your appetite is reduced, you may or may not reduce a dose, okay? Depends on how much you think you're going to eat. Some medications, oral medications, should be withheld. Okay, we know that SGLT2 inhibitors, for example, Jardiance, which is empagliflozin, dapagliflozin, so any of these medications that end with gliflozins should be withheld when you are unwell. And this applies not just for COVID, but for any infections or any acute illnesses. This is because these medications, when taken when you are unwell, can trigger what we call a euglycemic diabetes ketoacidosis, which is a medical emergency. Now, if you're not taking orally very well, meaning your appetite is very poor, some medications that may cause hypoglycemia, such as sulfonylurea, so for example, your glibenclamide, glipizide, gliclazide, should be withheld as well, because this may cause your blood sugar to go down to dangerous levels. If you're unsure whether your medications should be continued or not, please check with your regular diabetes care provider. Now, okay, so along with this, I think it goes unspoken that you should monitor your blood glucose. We've emphasized this enough. A lot of our patients may have difficulty with this, but I think I cannot emphasize enough how important it is to check your blood glucose. On normal days, you should already be monitoring your blood glucose levels regularly if you're on insulin. But if you're unwell, you should check your blood glucose even more regularly, okay? Up to 4 to 6 hourly, especially if your oral intake is very poor, you feel very unwell, you should check your blood glucose to watch out for very high or very low blood glucose. However, we understand that this may be constrained to some patients who may not be able to afford that many glucose strips. Then you should watch out for symptoms of hyperglycemia, which is high blood glucose, such as feeling excessively thirsty, frequent urination, and lethargy, or sudden weight drop. Okay, this is because excessively high blood glucose levels in the blood can cause excessive water loss in the urine, and the body weight actually drops dramatically. Or if you have symptoms of hypoglycemia, such as dizziness, palpitations, and sweating. Now, if you are type 1 diabetic at home, and most of type 1 diabetic patients have a glucose machine at home, and if your glucose machine is able to check for ketones and you have ketone strip, you should also check your blood ketones if your blood glucose levels is persistently more than 15 millimoles per liter. Now, how do we manage hypoglycemia at home? Okay, so it's important to know how to manage hypoglycemia, because this is a medical emergency and you need to manage it before you even come to the hospital. This needs to be addressed immediately as the symptoms come. So like I mentioned before, the symptoms are dizziness, palpitation, sweating, sudden hunger pangs, okay? Some patients severe may also lose consciousness, okay? So step number 1 is actually to check your blood glucose level, all right? If you do not check your blood glucose level, you do not know whether you actually have hypoglycemia. All these symptoms are due to something else. So if you confirm a blood glucose level of less than 3.9, immediately take 15 to 20 grams of fast-acting carbohydrate, okay? So this is what we always emphasize to our patients. These examples of fast-acting carbohydrates are such as sugary drinks. The best option is you have fruit juice, you have those canned drinks which have plenty of fructose in it, which is basically simple sugars that are being able to break down, that doesn't need to be broken down by your body and can be absorbed immediately. Okay, so things like bread and Milo, milk, okay, all this, they have carbohydrates. However, these carbohydrates are complex carbohydrates and needs time for the body to digest and absorb, and it should not be taken immediately during hypoglycemia. Now, only after you recheck your blood glucose levels, after taking sweet drinks or take a sweet, and your blood glucose levels that go back to normal, more than 3.9, and then take a slow-acting carbohydrate, such as bread, rice, or Milo, to maintain your blood glucose within the normal range within the next few hours. And always remember to recheck the blood glucose and make sure it's gone back to normal when your symptoms resolve. Now, if you need advice on whether your medications need to be changed after you develop frequent hypoglycemias, please do speak to your diabetes care provider. Now, last but not least, okay, as we are moving towards the endemic phase of COVID-19, this is a popular question that has come up amongst our diabetes patients on whether they should receive COVID-19 vaccines. As of now, I think more than 90% of our adult population has received first or 2 doses already. So now we are actually moving towards the booster doses. So we do know that patients with diabetes are prioritized to receive COVID vaccines. And now with the booster shots, the government encourages persons above 18 years old with underlying medical conditions, including diabetes mellitus, and who've completed 2 doses of vaccine to receive their booster shots. Okay, this is also in line with the US CDC guidelines on who should receive the booster doses. For patients who have taken Pfizer or BioNTech, Pfizer-BioNTech vaccines, they should wait for at least 6 months after their second dose. And for patients who have received Sinovac, you can receive it if it has been more than 3 months after your second dose. Now, lastly, after all the doom and gloom that I have painted on COVID and diabetes, I would also just like to bring up some positive points that might have come up during this course of this pandemic. Now, on the bright side, we have witnessed rapid development of medical science over the past 1 to 2 years. We've seen that the COVID vaccines have been developed within a very short period of time because of the large amount of political power and money that has been put in. I think at the end of the day, that is also all the top brains in the world have put in their efforts into developing medical science because of this global pandemic. Also, it's been very encouraging to see that finally we're adopting telemedicine as an option for delivering our patients' care. And this is also very pertinent to our theme of our World Diabetes Day this year, which is access to diabetes care. And during the peak of the pandemic especially, so patients who do not want to come to the hospital or just have an appointment to come to the hospital for very minor issues to discuss with the doctors, which can be done via either a telephone call or even a Zoom meeting, have the option to do so. And I must say that actually this technology has been around for many, many years, but it has taken a pandemic to actually push this forward as a viable option for patient care. Also, evolution of medical education. As you can see, now we have all this webinars and Zoom meetings, such as the talk we have today, and we're able to reach out to much more people with this widespread adoption of online medical education. So we've seen increased focus on healthcare sector. Okay, our national spending on healthcare also has been increased, and hopefully this is a good sign of things to come. And last but not least, I do think that if we had this pandemic 20 years ago, we might not have fared as well as we have fared today, okay, because of all the technological advancement that we have, okay, including technology-assisted treatment and all this communicative options that I've mentioned previously. All right, thank you very much. That wraps up my talk for today, and I do welcome any questions.
Thank you, Dr. Lim, for explaining to us regarding the interrelationship between COVID and diabetes and the do's and don'ts for patients who have diabetes who are infected with COVID. Okay, let's move on to the first question that we got it pre-event. That is there a difference between the risk of type 1 and type 2 diabetes patients to get severe COVID-19 infection?
Okay, so based on the current available data, based on observational studies, actually, there is no difference in terms of the adverse outcomes, including admissions and complications of morbidity and death amongst type 1 versus type 2 diabetes patients.
Okay, thank you. Next, we'll move on to the second question. What's the rate of newly diagnosed diabetes among the COVID patients who gets admitted?
Yeah, that's a very good question. I think for us to actually have an accurate representation on the rate of newly diagnosed diabetes in COVID versus non-COVID era is virtually quite a difficult calculation to make. But we do see that has been an increase in rates of newly diagnosed diabetes amongst patients with COVID-19. And it's also been speculated that COVID-19 itself actually can trigger diabetes, a new onset diabetes. And it's been shown that COVID has been found in the pancreatic beta cells, and it may be the cause that the people are actually postulating that COVID-19 itself is causing beta cell apoptosis or beta cell death that is leading to new increased rates of newly diagnosed diabetes. We have also seen increased rates of DKA or HHS amongst patients who previously had well-controlled diabetes, okay, and when they have come in with COVID-19. But the evidence in all of this continues to grow, and it's exciting to see what else we can learn from this pandemic, from the data that keeps coming out.
Okay. Next, we shall move on to the last question for the day. How is diabetes managed among the COVID patients to lower the risk of transmission to the healthcare workers? Like previously, they might be injecting 4 times in a day insulin, but once they are admitted in the ward for COVID, is there any role for the insulin to be reduced to twice a day, like mixed usage? And how frequent do we measure the blood sugar in the ward?
I think it depends on how safe it is for us to actually do that. Because like I mentioned, when patients, we know that when they are admitted, they are in a higher stress setting, their blood glucose may actually go higher up, okay? And we know that patients who are admitting for COVID-19 requires more insulin to actually sustain within a normal range of blood glucose, especially if they are also given corticosteroid therapy, which may drive up the sugar even more. So we may try to balance off reducing healthcare workers' exposure by asking the patient themselves to check their blood glucose levels while they're in the ward, okay, so that our nurses don't have to go in every 2 hours or every 4 hours to check their blood glucose, just to check their blood glucose, and being a massive waste of PPE as well. But when it comes to treating the intensity of insulin treatment, I think patient safety must come first, okay, and we cannot take shortcuts to which may compromise patient safety in the ward, especially if the blood glucose goes high. We know they need more, and the higher chances they may actually need intravenous insulin, which is more intensive insulin therapy when in the ward.
Okay. Thank you, Dr. Lim. Indeed, COVID had made various changes to multiple fields, and medical is not spared too. With that, this ends the session for today. Next, I will hand over to Dr. Lim and also Dr. 𝒑𝒂𝒌𝒂𝒓 for the closing ceremony. Thank you.
Welcome back, everyone. Thank you for staying with us till the end of the session. I think this has been a very fruitful event, and I'm sure a lot of us have learned a lot of things, myself included.
Yeah, hi, I had learned a lot also through my conversation with Dr. Lokman, and thank you all the audience. We have like almost up to 200 on live, all throughout the event. Yeah, that's actually a very great participant number. Thank you so much, everyone. So now we'll move on to announce the winner for our pre-event photo contest on social media.
For those who are not aware, we had a pre-event promotional photography contest where participants only had to submit a photograph with a theme of living positively with diabetes on either any form of social media. And we've selected a few entries that are most creative to win some exciting prizes. So, yeah. So for our, okay, there's no number 1, number 2, number 3 lah, okay, but we had 3 main prizes, okay. For the Huawei FreeBuds 4i earbuds, the winner is Irina Hanis or AM_Gremlins. Okay, for
the second prize is our Samsung Galaxy Bud 2, okay, which the winner is
Muhammad Khairi.
It's Muhammad Khairi. Okay, Khairi, how can you? Okay.
And lastly, for the Huawei Watch GT2, the winner is 𝒑𝒂𝒌𝒂𝒓. Okay, so thank you for participating in this event. Your entries were very, very interesting. Okay, if for those who are interested, you can just click on the hashtag WDD UMMC 2021. You can see their entries. So for the winners, congratulations, and do contact us at this email to claim your prizes. Otherwise, we will also reach out to you. Okay, we will send the gifts to you.
Okay, so next, this is our feedback form for this event. Kindly fill up the feedback forms so that we know what topic to focus on for the next year, and just tell us which is your favorite speaker.
Yes.
Yeah.
So on behalf of the whole organizing committee, we would like to thank everyone who stayed with us, okay, everyone who's watching. And this video will continue to be on YouTube, and we hope we will continue to benefit more and more people, patients with diabetes and their carers, or anyone who's interested in general. Please do continue to watch it and tell us what you want, what else you want to learn in our next event. Thank you very much.
Thank you.